I can. Record the time you do it, obviously, anytime you give a med, and their reaction to it. There is a problem with albuterol and asthma, which is why they're only supposed to take like 3 times. Albuterol can actually start causing the very tightness and inflammation that you're trying to prevent. It has what they call a rebound effect. So you don't want to keep doing, if they've already had albuterol, you don't want to keep doing over and over and over, because you're going to actually start causing problems. And that's where the dual nibs come in handy here too.
Only 30 to 40% of oxygen. Anything remains at the same time?
With your, this thing? Probably, yeah. I don't know why not. I just crank the oxygen up.
Yeah.
You can go up to 12 or. Nasal cannulas aren't messing with what's going on here at all. They can still breathe it out past it. There's a picture of the meter dose inhaler with the expansion chamber on it. I don't know why they don't give those to everybody. And it talks about the powder inhalers. Okay, if all this is not working, and you're having to help, yeah, high flow diesel. CPAP is something that's becoming more and more prevalent in EMS. We don't have it yet. We do have a gadget that can teach us how. I mean, it's real simple. You put the mask on and you do this one thing, and it will give them CPAP. CPAP is a continuous air going in. So it's like you have the wind blowing in your face all the time. But there's a lot of disease processes that this can make a huge impact on. Everything from diabetes to how well you're sleeping at night to bronchitis to my husband has not had a bronchitis episode since he got on the CPAP. Actually, I think it's great exercise for your lungs because you have to be able to breathe out past that wind that's blowing in constantly. So they actually get a lot more use of their lungs that way. We can assist with bag valve mask if that's all we have. It gets really tricky because if they're conscious, they're going to be fighting you off and saying, get away from me. I won't let you. So that's what CPAP is. BiPAP is 2 levels of pressure. It actually gives you the high pressure and then low pressure to let the air in and help it go out instead of being high pressure the whole time. Then they have ventilators, which we do not have. If we want a ventilator, we need to call the paramedics. First question he asked me on my last run with the paramedic was, do you know how to work the vent? No. Not my level, sorry. So be aware of both those things and how they work, basically. CPAP is probably coming. If your service doesn't have it, I see it in the near future with everybody, because it does make a huge difference in how they breathe, especially those ones that are saying, I can't get enough air in. Because it helps. Yeah, it helps inflate all those little things, the little arterioles as they're trying to collapse. It helps inflate them and keep them open. That's what the positive pressure does, is helps keep them open. Because they'll start collapsing on you through various disease processes. Okay. Acute pulmonary edema is when the lungs fill up with fluid quickly, suddenly. It could be caused by aspiration of something, whether it's food, blood, whatever it is. COPD can cause it. We talked about asthma. Anaphylactic reactions can cause it. We're going to talk about them more later. Which, yeah, early administration of epi is your priority in the allergies. We talked about the spontaneous pneumo. I think I pretty well covered all those. People who have tracheostomies. So they're now breathing through this little hole right here. A lot of the problem there, when they can't breathe, it's because of crud that's down in there. So suction, suction, suction helps get the crud out. Remember, when they have that and you're giving them oxygen, this is not going to help. You can actually almost take the tube and stick it directly in there, but use a PED mask and it'll fit right over it nicely. And help be sure they have the oxygen they need. It goes into, since COVID-19, here's all your little things to doff and don. Do you have those? No. Okay, this is part of what's added. We went through, you were all trained probably, and how you put the gown on exactly just so, and then you put a pair of gloves, you put the gown on, you put the other gloves over, you tape the buckle around here, you put your mask, the order you put everything on and the order you took everything off was important. You had to have somebody watch you put it all on and watch you as you took it all off and threw it away and bundled it up in a little ball and put it where it was appropriate so it wasn't spreading the disease. Kind of a lot of big panic for not much. Don't get me wrong, yes, some people have really bad, some people die from COVID, people die from colds, people can die from flu. Okay, any questions on respiratory emergencies? What? The COVID or the vaccine?
The COVID.
It did. That was one of the things it did, was fill the fluid sac around the heart. And it caused enlarged hearts, and it's still causing problems in some people. Okay, cardiovascular. We talked about basically how the lungs, heart, and lungs work together. Remember that we talked about the flow of blood, but remember your electrical system. Do you remember how it works? It starts with the SA node, which is at the top right side of your heart. When it is the pacemaker and it's doing what it should, you're going to have a rate of 60 to 100 per minute. If that fails, it goes down to the AV node, which is in between the atria and the ventricles. If that one takes over, your heart rate's only going to be 40 to 60. From there, it goes into the down to, they called it something different. Goes down into the Purkinje fibers, and they start, your heart rate's going to go to like 20 to 40, or you're going to get fibrillation where everything's just firing randomly. So ideally you want it up here. We talked about, be sure you know difference between preload, afterload, cardiac output, contract perfusion is whether the tissue's getting that. Contractility is how hard the muscle is contracting, which can change and will change. Then it's of course connected into, it counts on that lungs doing their job. So the blood goes in round and round, and air goes in and out, and you're good. Problems start occurring. You get atherosclerosis, which is when the fatty material starts building up inside the arteries. You got it. I can tell you what page you're on. Which causes a reduction of blood flow because the inside diameter of your pipe is getting smaller. Not because the pipe is changing, but because you're filling it with crud, sludge that's not washing out. So if you're irrigating and you have really sandy dirt, and sometimes you go to pick up those pipes, there's all this sand in it, and the irrigation's not going as well as it could because it's getting plugged up with something. It also causes the arteriosclerosis. Usually happens more with age. where the arteries get tired and they start getting harder. And that makes it harder for them to constrict and expand. So the elasticity is going away. They're not as able to react. That's the difference between those two. One's more age, one's what you're eating. A thromboembolism is a blood clot that's floating around through there that floats through your bloodstream until it gets to a small enough blood vessel that it just occludes it. And that's where you get strokes and heart attacks and basically pulmonary embolism. It's interesting, they compared strokes to heart attacks in this book, and I thought, I never really connected that, but they are basically the same problem. This one's in the brain. Acute coronary syndrome is used to describe any group of symptoms that goes along with acute ischemia. What's ischemia?
Lack of oxygen to the heart tissue.
Okay, it's muscles, part of the muscle that's no longer getting the oxygen. And it's causing damage, and eventually it leads to death of that part if it doesn't get oxygen fast enough. That's what's causing your pain. Your muscle saying, I need air. I'm dying, and it is dying if you don't get air to it. So that's why anything, the pulmonary embolisms, the strokes, the heart attacks, get them out of here fast. These are the true emergencies. They don't have time to keep thinking. Time is muscle in these cases. Time is brain tissue. Time matters a lot. So angina is caused by the discomfort when that's happening and it's blocked. Sometimes it can become blocked as your blood vessels are constricting because of something you're doing. And once you relax, it goes away. So sometimes the pain comes and goes. When you're working and causing more stress on the heart, it can cause the pain. The acute myocardial infarction, most of the deaths are caused by dysrhythmias. So when you have a sudden heart attack, it's usually because of a dysrhythmia. The heart's not, that's not the blockage, it's the rhythm or an electrical problem. They get sudden onset of weakness, nausea, and sweating without a known cause. So they're suddenly profusely sweating without having done anything. They will get that pain or just uncomfort or pressure. It can be here, right mid-sternum. It can be in the lower jaw. It can be in the shoulder or the back. Where did you feel it at? Left arm. She was complaining of her left arm one day, and I was flying in here to see what the heck was going on and put an EKG on her, and she passed me going to the hospital. So I figured it was okay. She was still going in the right place. They don't always call it a pain. It can just be pressure, tingling. An irregular heartbeat or fainting, syncope is the other word for fainting. Remember that weird word? They get dyspnea, can't breathe. They might have pink frothy sputum, which would indicate pulmonary edema going on. And you can get sudden death. They might just be walking down the trail in front of you doing just fine and suddenly do a face plant. We had one that we were called on that did that, just that. He was walking down the trail coming out from the wilderness area and just did a face plant. Happened to have a doctor on the trail right behind him that started CPR and actually called the code before we got there. The general appearance, they might appear frightened. They might have nausea and vomiting going on. Why would they have nausea and vomiting going on? Any guesses? Your sympathetic nervous system's kicking in, trying to keep that going, and it's shutting down what's happening in here. So they would have nausea and vomiting to get that out of the way so they get more attention where the attention's needed. Um, keep in mind, not everybody has the same symptoms. They can have really weird little symptoms. We were called to a lady recently that said we were paged to can't breathe because of an allergy to Tylenol. That was it, allergy to Tylenol that she had taken 3 days before. And she just had surgery, okay? So you're thinking, is there pulmonary embolism? Is it really an allergy? Something, as we went from between here and Moreland, I was pretty sure she was having a heart attack before we got her there. And she was having a heart attack. And we got to talk her into letting the nice people send you the billings and get you fixed. Did not want to go. So they may not recognize it. It might just kind of sneak up on you. People, they say, I get a kick out of the American Heart Association video that says, people may not want to think they're having a heart attack. I have yet to come across anybody that says, I'm having a heart attack. Usually it's, oh, I don't know why they call it. Oh, I'm fine. It's going to go away. And you say, and you look at their color, which gets kind of a cadavery gray, yucky looking color, that you can look at them and say, ooh, you are not well and your heart's not good. Because they're not getting the circulation they need. They say middle-aged men are particularly likely to deny their symptoms. I would beg to differ. Maybe we just have stubborn folks living in Wyoming, but they are as stubborn as can be and will not. No, I'm fine, I'm fine. This is why every time I teach CPR, I say, okay, guys, I don't care what town you're in, call the ambulance, tell them blame me, here's my phone number, they're welcome to call and yell at me. I don't care, you call the ambulance. Okay, so the general appearance, the bluish color, the cyanosis, the gray is not good. Their pulse usually increases as a response to pain and stress and fear. Because the dysrhythmias are common, it's probably going to be irregular, and it may even be a slowing of the pulse rate as the different pacemakers are taking over. It might get slower and slower. The blood pressure may fall because the heart is not it's not pumping out the blood the way it should, so therefore that's not circulating the way it should. So the pulse is increasing, trying to make up for that, which is still not helping pump it out because it's the pump that's broken in the first place. They complain of difficulty breathing, and you can look at them, they might be perfectly normal rate and rhythm, no sign that they're having trouble breathing, but they feel they aren't because your cells are not getting the oxygen they need because the blood's not carrying it. When I first donated double red blood cells one day, I was surprised. I felt like I couldn't breathe for like 2 weeks. My lungs were fine. There was nothing wrong with my lungs, but my cells were suffering because the carriers were missing. And it made a lot of sense, actually. I should have expected it, but I did not. Mental status. Pay attention to mental status. If a patient in this condition tells you, I feel like I'm going to die, they probably are in the process of dying if you don't intervene and do something to get it taken care of quickly. There are some strips, cardiac strips, that you guys are starting to be expected to know. Figure 18.8. Your top one is sinus tachycardia. I can tell you it's I don't know. How do you go about this? What that is. You come across, get a little bump, and it does this big thing, and then you got another bump, and then you have a waves in between. Okay, this is the P wave. This is Q, R, S. This is the T wave. So QRS is put together, they call it the QRS complex. If it has a P wave for every beat, it is a sinus rhythm. That doesn't mean it's good, but it means it's sinus because there's a P wave for every beat. So if you look at that first strip, that first little bump before the sharp up and down thing is there every time. Yeah, it is going pretty fast. It's faster than it should be. That means those little peaks are all a lot closer together than they should be.
Becky, I have a question for you.
Yes,
Okay, maybe a stupid question, but can EKGs be done while the ambulance is moving?
not very well.
Okay.
You can, but you get a lot of artifact from the road. So you'll see this. Oh, come on, Pam. You'll see.
Okay. Yeah.
That's not their heart, that's the road. You
Okay.
can get that from fluorescent lights. You can get weird
Okay.
things going on. And every once in a while, I had it on a lady the other day and it was going terrible like that the whole way. And all of a sudden it was perfectly clear, just long enough I could quickly print a strip. And then it went right back to that again.
Okay. Thank you.
But if you look at number D on figure 18.8, and you see those little ripply bubbly things there, that is ventricular fibrillation. So is this happening because it's atrial fibrillation, and then you have the beat, and then it's fibrillating? Or is it happening because of the road? That's why you stop and you run it when you're not moving. So ideally, if you're doing an EKG, it'd be best to do on scene before you leave. They don't take very long, but yeah, they take. You should. I'm bad about waiting till I'm on board. Okay, so if you look at B, see how far apart those peaks are. They have P waves each time, so it's a sinus rhythm. But when they're that far apart, you've got bradycardia. It's coming way too slow. On C is your VTAC. You kind of lose your P waves and you just get these big bumpy shark finny things, they call them. And on C, it's ventricular fibrillation. Atrial fibrillation is just kind of it is like this. It's weird wavy. There are P waves in there if you can see them. This is kind of exaggerating. It does have a normal that thing, but there's no P waves to atrial fibrillation. And D, the fibrillation can start really wide and big, and it gets narrower and narrower and narrower until it actually makes the little flat line, which is asystole. Heart's no longer pumping. That's the easiest and most stable cardiac rhythm right there. You can change it, but it's very stable. Very hard to get it back sometimes. The ventricular fibrillation. Pulseless. Ventricular tachycardia, when it gets going really, really fast and it's not getting any blood in it and you no longer have a pulse coming through because there's no blood circulating. It can shock that. How it recognizes there's no pulse, I don't know, but it can shock that. So pulseless VTAC, VFib are the two it shocks.
But in the track.
And it wasn't because he got the fibrillation, it was because of that. Those of you who know GARD, I don't know if I've told this story before. One time he was talking about AEDs and how they worked wonderful, and he took it and he stuck the AED on himself. And of course, it wouldn't shock. It said, no, you have perfectly good rhythm. And he says, so you see that it does its job. It recognizes when there's a rhythm, it's not to shock. So then he got silly and said, now, if you really needed it to shock, you could probably wiggle the wire. And you started wiggling the wire and it said, shock advice, charging now. Amazing how fast those pads came off. And you know, in the American Heart where they tell you push it down and then rip this hair off, yeah, they do go, ah. By golly, they came off. That was a one and only time attempt. He never did was foolish enough to do it again. No. Kind of like the EpiPen episode. Never happened again. You know, I would really hurt the finger. That would almost go clear into the bone as it goes so deep in the muscle. Oh dear. Okay, so those are your rhythms it's going to recognize. What is cardiogenic shock? There are only certain kinds of shock. We haven't really gone into shock. I'm leaving that one up to Dr. Miller because he's very good at that. Cardiogenic shock is often caused by heart attacks, myocardial infarction. It doesn't have enough power to pump. It's pump failure. Cardiogenic shock is pump failure. When the heart's no longer pumping enough, it can happen with the heart attack. It can happen hours after the heart attack. It says it can be up to 24 hours after the heart attack, after the MI, before cardiogenic shock can present. It has, yeah, it's always real good when they give you definitions. You can have chest pain, difficulty breathing, fast heart rate. You can have either fast or slow heart rate. You start getting peripheral edema, which means what? Swelling out in the arms and the feet. You get dysrhythmias, you start seeing what's JVD. Yeah, you see these veins sticking out. You start getting crackles, formerly known as rails, when you listen to breath sounds. It's because the body's shunting blood elsewhere and it's not getting done. So keep them in the position of comfort when you move these people. Oh, heart problems. When you see the signs and symptoms, they might find it easier to breathe when they sit up. That's orthopnea, by the way. When you breathe easier when you're sitting up. ORTHOPNEA, orthopnea. ORO. Oh, I'm sorry, ORTHO. OROTHOP. I'm sorry. Or yeah. That's when you feel like you can breathe better when you're sitting up. People who are in respiratory distress do not want to lay down. Let them sit up. With, which one was it? Okay, we're talking about heart failure. They want to remain in a sitting position with their legs down. They don't want them up on the cot. Turn them sideways, let them have their legs down. You can strap across here and you can still kind of strap across the chest, maybe. No, because you're going to be moving them a couple of times if you do that. Just let them sit sideways in the cot. It's fine. Strap them best you can, but let them stay up with their feet down. I had a respiratory one that wanted her feet down. Probably one of the last trips I took her. I took her a lot of times before it got bad enough they finally kept her in Moreland. People in heart failure, CPAP would be beneficial. If we don't have it, call paramedics, let them come do it. Try to gain IV access. Are we going to give these people a lot of fluid? They have edema going everywhere. So as if they're in shock. Okay, they're showing signs of shock. I would give it very judiciously. Mainly, why are we starting an IV then? Get the access. People having a heart attack, start IVs, 2 large bore IVs, large as you can. That doesn't mean they have to be 14, 16s, 18s, but get them as big as you can. Get them as soon as you can. Because I can't tell you how many times we get them to the hospital and they say, man, I'm glad you got that IV because nobody else could. Because as they're shutting down, those vessels are going away. So the faster we get them, the better. They need a bigger one than what can go in there.
No, they did it here.
Okay. So remember, yes, you're starting down here first and then working your way up, but there are times that they need them large bore and up. That doesn't mean, aha, I see that. Yeah, I guess I'll try it. And if I mess it up, I mess it up. I mean, if that's your only vein and it's not going to deteriorate on you, I would just leave it and let them have it. But if you can get it, get it. Try not to mess it up. They kind of frown on that. Okay, a dice, what is an aneurysm?
Weakness.
Yeah, the walls of the blood vessels start to weaken. So they kind of balloon out
Yeah.
in the artery. We can work with this. If you're looking down your artery, this is your lumen. If you're outside of the artery, we just sliced it in half and we're looking at it. This starts to balloon out because it's getting weak. And a dissecting aortic aneurysm, I believe, is the one. This is going to weaken out and it's going to start bleeding up into here. They will talk about a tearing sensation because it's tearing that apart. She called that heartburn? Whoa, must be one tough lady.
Yeah.
So it goes into the layers and starts separating it. If it keeps breaking through this and we don't get it fixed fast enough, it's obviously going to explode eventually. And you're going to have an aortic bleed now. And you're going to have they're not going to last long if it doesn't get fixed.
So Becky, I have a question for you. Do you know
Yes.
why sometimes they monitor them, but they don't treat them? Do you know why?
Okay, that's probably, that's not where it's tearing up into the aorta. There is something called an abdominal aortic aneurysm,
Okay.
where it starts to balloon up like that. It's not into the layers. It's ballooning this way. So it's still there, but there's a weak spot. And they will wait for it to get bigger and become a problem.
Oh,
That's the one, if you're palpating the abdomen, you want to be kind of careful. And if you find some big mass in there,
okay.
just lightly kind of touch it and see if it's pulsing. If it's pulsing, do not poke it. Get them to the hospital fast. Because if that explodes, they're dead.
Yeah. Okay. Thank you.
And you get the same thing in the heads. That's the brain bleeds, the worst headache I've ever had in my life. And when that ruptures, it can kill them instantly. Hey, that's not my marker. You left your marker. Break time. Oh, it is 10 o'clock. Ask these people how you feel and describe it to you. Some patients may not feel pain. They might just kind of feel weak. They might feel a little bit dizzy. They might pass out. Let them describe what the pain feels like. If it's pressure, crushing, squeezing, a lot of them will say, it's not really pain. It's just kind of pressure. I mean, if somebody comes up and squeezes your arm, it's not really pain. Although it gets that way when they put blood pressure cuffs on that won't go down. Ask them, have you ever been diagnosed with angina? Look at their list of meds. Well, heart failure, heart valve disease. Have you ever had high blood pressure? Have you ever been told you have an aneurysm? I don't know why they would watch it, but they do. In my mom's case, why her heart was bad is she had a hole in the septum between the two sides of her heart. And they just kept watching it for a lot of years. And finally they said, okay, now it's time to operate. She knew she had it from when she was young. And she was probably, 50 or older than 50 when they finally operated on it and closed it. Took a long time. I think part of that is medicine keeps getting better. And it wasn't bad enough, it was causing bad enough symptoms, I guess. You weigh the pros and cons of the surgery, and if the cons are still higher, they're not going to do it. When the pros get higher, then they do the surgery. Ask them if they've ever had diabetes or had problems with blood sugar. Have you ever had kidney diseases? Do you have risk for coronary artery disease, such as smoking, high blood pressure, or high stress lifestyle? No stress. We don't have stress. Is there a family history, and are you currently on any medications? If they don't know what angina is and you say, what meds are you on? And they say nitro, obviously they have had angina because that's what it is for, is to stop that. Be sure and question very carefully your OPQRSTs, especially the time they started. Anything that they have a clot in there that might have to use the clot buster drugs. There's a time limit on them. We need to know what time it started. Or, yeah, it's been progressively getting a little worse. Okay, why did you call me today? And what time did that start? Because maybe the blockage was coming. Ah, it's here. You need to know what time it changed. Things for cardiac patients: do not walk this patient to the stretcher. You take the stretcher to the patient if at all possible. If you have to walk them out, be sure you have people on both sides and you are assisting them. You can use CPAP for patients with dyspnea or pulmonary edema who are alert and able to follow commands. You can't use it if they're not alert, apparently. Always check blood pressure before you give nitro. The other thing, now that you're AEMTs or will be AEMTs, do not give nitro till you have an IV in place. Free flowing IV with fluid connected. That doesn't mean it has to be wide open yet. But if you give that nitro and their blood pressure tanks, it's too late to be playing catch up and trying to get an IV in. Because you may not get that vein again. So check your blood pressure. What does blood pressure need to be before you can give nitro? Systolic needs to be at least above 100. I gave it to a lady that was like 160 at one time, and she dropped down to like 90 in one dose. And she told me she was going to do that. And I didn't believe her, and I did not have the IV in place. Why? That IV, I could then give fluid and get that blood pressure back up. You want to keep it at least 90. You don't have to have it at 120, but at least 90. Below that's not good. Take any medication patches off these people. especially if they're found unresponsive and hypertensive. They have nitro patches now. Some people don't take off the old ones. They can overdose themselves with the patches. You be sure and wear your little gloves so you're not knocking yourself out in the process. Wipe off the skin. Administer IV fluid very judiciously in people complaining of chest pain. Give it in boluses if the blood pressure is low, just enough to keep it up. Because if we get too much fluid in there, it can increase the workload of their heart too. If a 12 lead is attained, you slap it on, you get your 12 lead, you send it off to the hospital, or you hand it to the paramedics who know what to do with it. Don't take your little stickies off. Leave your stickies where they are. Then they don't have to put another set of stickies on. Not always. Their ends can clip right under the ends of ours. Ours snap on. There's clip on, but they can clip it to it. Sometimes they do. But leave your stickies. You might want to take another, they might go downhill as we go. We might take another reading and record it. Yeah. If you cannot send the EKG to the hospital, print it out. There's a button that says print your EKG, print, and go. You can actually probably send a picture of it if you had to, but it's harder for them to see and understand what it's doing. Keep in mind, cardiovascular emergencies are very rare in kids unless they have a congenital defect. So in kiddos, it's probably going to be pulmonary that stops the heart, not the heart itself. Older people are going to have different symptoms. They're going to be reacting different. They may not realize they're having a heart attack at all. To administer nitro, we carried little pills that used to have a spray. The spray's kind of going away. I don't know why. I think because there's another spray that got confused with, and it used to kill people by mixing them up. But you're going to take one little nitro, you're going to have them lift up their tongue, you're going to put it under their tongue, and they're going to keep it there till it dissolves. They don't chew it, they don't swallow it, it has to stay under that tongue. Don't let them swallow water. If they have a really dry mouth, you can give them water before giving them the nitro. Make sure they don't swallow it and swish it around. Spit it out and then put the nitro in because it'll help it dissolve if there is moisture there and not super dry. Okay, there is, you open somebody's shirt and look at them, they have this really beautiful scar coming right here. What's that telling you? They had an open chest surgery at some point. If you look at the x-rays, I don't know, do you have an 1811?
Yes.
On a person who had open heart surgery, going down that mediasternum, you're going to find little bow ties. Looks just like this, little bows tied going down it. That means they had open heart surgery. They can have an implanted cardiac defibrillator. Our last little patient who had a defibrillator, or is it a pacemaker? I think it was a defibrillator. Did you even notice it on her? Was me and Gabby on that one?
Yeah.
I thought we had a third person. Okay, just the two of us. I didn't notice the implanted defibrillator on her. Yeah, they make them smaller and smaller, and you may not see them. This was I think she's 17 years old. It has a defibrillator implanted here in 10 Sleep. Well, she's not in 10 Sleep, but she was here. She's here sometimes. So You'll just kind of see the lump under the skin on either the right or left side. It's usually on the left side, but not always. They can actually wear a vest that's a defibrillator. And then they have, that's what they call it, LAVD, left ventricular assistance devices. Is a little pump type thing that they put down into your left ventricle because your ventricle isn't working, and it just pumps the fluid around all the time. So you may not have a pulse, you may not hear a pulse, but the blood's circulating. Makes it really hard. If that isn't working, you need to listen to the chest and see if you hear a hum that indicates the device is working. If it has a display screen somewhere, you look at it for an alarm code. If you ever have to replace batteries, only do one battery at a time. Because apparently it has a couple of them. If you disconnect them both, then it's not going to work. And it's not circulating. They say that people often have an 800 number to call for information if they have one of these. And there's usually in adults, but there is one approved for kiddos from 5 to 16. So you can find them in someone as young as 5. You'll probably know about it though. Okay, AEDs, you've all got AEDs down pat, right? You understand early defibrillation and the safety. You know, your special things you need to be aware of. Figure 18, 17, 16, and 17 show you the limbs where you put the leads on to do a 12 lead. And then you either send it away. You want current pads. Your little sticky dots can become old and dried out. And if that gel's not there, it's not going to read properly. So you want to be sure that you don't use expired things, or if it looks dry, you might need to replace it if it's complaining about the pad. Those are the positions, how you put them on, get your 12 lead and send it to the hospital is what your protocol is. Those cardiac meds are intermediate. Okay, any questions? Let's take a break before we hit neurological. Let's meet back at 10:15. 7 minutes, long enough break, or do you need longer? Go to 10:20. 10:15. See you back. Oh, the recording is paused. It has not been recording.
And it was a big merge of drivers, like, where they could see the whole thing. I'm glad that you're there. Yeah. They care. Right there. There's the field.
Usually they're kind of like a corner of the field right up against the fence, but they're not.
We walked over there last time with the ambulance. And it was like hanging on to the guard. And I was like, let's just say hi.
So they got cranky last year because they got across the field, all the way across the field.
Yeah. So they have us fight at the white gate.
That gate's leaving locked.
Mm-hmm.
If we truly need to go on that field,
Yeah.
like, do you know where the
Shane
train
had
is?
That's
Good to know.
That's what they told us at the last game.
when we were in parking, he was
He
like,
was like, I'll get the ambulance and get it if you need it.
you're like, right here. But you have a key, yeah. Well,
In all honesty, the last time I was pretty disgusted too. Was a wrist, was it not?
Yeah.
We have a wrist injury,
Yeah.
right smack in front of the concession stand.
Well, and I think.
Why can we not walk the body this way? Put it in the
Well, and
ambulance?
it wasn't a risk, it was it
It
was
was
a
a-
warrant.
Well, yeah,
Yeah,
But it was his
so
kid.
did
too.
that require driving across?
no, but I think it's because of
Yes,
that.
Fine,
It
yes,
was
that's
his
because
kid,
of that.
it was-
Like, I probably would have freaked out a little more too.
Yeah, cause I didn't even notice that Sam went to get it, I'm just there wrapping the arm, and next thing I know, there's an ambulance, and I'm like. Oh,
Nice.
he's like, do we need the cop? I'm like, no, he can walk to the ambulance. I know.
No, it will be fine.
I know.
Okay. We go faster, 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 faster.
So the surgery was done on meeting Tuesday. So I'll drop them off. I have Nicole's phone. I was gonna hurry into yours
I'm not gonna be here Saturday anyway.
this morning.
Oh, you won't be here.
But then there's a game 2 days on Tuesday at home. They changed the schedule, they changed it. So Riverside's playing here and Riverside's playing Riverside there. So on Tuesday, September 26th. we
But
have a
that's
home
just
game.
middle school, right? Or.
That's right. I know it's a middle school football. I don't know. So we have 2 more home games. Do we not need to be there for just middle school?
Oh, no, we do.
Okay. It's at 12.
I was
On
just
Tuesday,
trying to figure out.
I won't be, I'll still be.
Oh, okay,
Is it high school too?
well,
Too many things going on today, people.
where was it? Supposed to be?
It was supposed to be October something. In. Basin.
Because we have high school volleyball home. I remember seeing.
When they like, yeah, it was originally on, October something,
The September something?
the September 26th. So it was originally October 21st. And now it's on September 26th at home.
Oh, see, they don't even, oh, it's a high school football. HEM home at 2:00. So ours is always home.
Where it's
September
26th?
Oh, October.
Okay, you know, on here it says middle school football, so high school must not be playing because if high school's playing, it'll say high school football.
Where are you?
On the website,
Yeah, so ours is October.
and then middle school. Middle school,
Okay, so it's just middle school.
yeah. So there's no middle school game on the 26th.
On a Tuesday at noon.
Let me send you this.
I have it somewhere.
Well, I just, you want this one for the middle school? It's right, it's made.
Yeah.
During the day.
Oh, I don't know, yeah. I probably have enough time to make sure I can get that time off.
It's and too.
I guess we haven't discussed who's doing. The game on.
We need a free Saturday. And I'm not here.
I'll be there, so.
And Grant didn't do the parade.
Right,
You might do the game too.
I'll send a message.
I will not.
It would be handy. Sarah is dropping out of the class.
She is.
It's too much.
Too much going on and health not being good.
She's gonna have a. She was telling me that she's gonna do some more cardiac things. We're almost wondering about her kidneys.
If they're looking at kidney things, yeah. Wondering if that's what's causing the problems.
But you would have a tracker. There. Yes, I did the football.
But she says she keeps going, her sugars are dropping all the time, especially if she's in the sun, and so it doesn't matter if I'm eating, not eating.
She was starting.
You gotta eat more than that. Problem is eating sugar, we'll get to that. That's in today's part. Oh, I missed that page.
Yeah. You're into it. Yeah, football.
Ask Ernie, because he has a nasty habit of not telling me when games get moved and then expecting me to be at them.
The 12-2. We don't do the volleyball. No.
Hmm.
We don't have the way.
He's always there.
I just won't do it.
You don't need it.
I won't be there though.
Oh,
And he knows that. I don't know what he's gonna do for a chain cream Saturday. I talked to him and I don't know where it's like he's dropped off the face of the earth. He's not answering me. Maybe he got a new phone number.
I don't know. I think the other day. Or coming down.
I think he's dropped off the face of the earth.
And I had just seen her that morning. Like I literally just saw her because it was that day we had that call.
Maybe they're being antisocial.
Really out there.
That's you guys.
That's me.
Who are
You want
you?
me to check it over? We need some.
Oh,
26.
Mhm.
So there's a home.
and you said you're not there.
Will you be there on the
26th?
Yeah.
You are?
I'll be back soon.
Oh, okay. Yeah,
On
so
Friday,
I
you
will
also
be, so I'll look at my schedule.
Trying to remember when I was working on scheduling a CPR class.
The other one. Yeah. he's going-
About Graham
Right,
or Ann and myself.
yeah, but it's something a lot.
But Graham. That's not it. Because Sarah's working, she can't. Well, she might be there because her kids are playing.
Right.
It won't be like an hour and a half. Like all the next games are weekly games. Except for homecoming. There's the one in Matisse on a Thursday, and then the one in Burlington's on a Friday. So Matisse is until 5.
Oh,
Too many things, too many things, too many things. All right. It's not B-O-E. Okay, guys, back to this. Faster, faster, need to go faster. Okay, neurologic emergencies. They're sending me messages from across the table. It's one of the whole group, but still.
You know,
Okay.
that's the terrible thing about technology.
It is. I need to, well, here, I can solve that. No. Silence everybody. Okay. Central nervous system. What does that involve? Brain and the spinal cord, and then you have a peripheral nervous system that has the rest of them. It comes down, 12 cranial nerves run directly from the brain to various parts of the head. The rest of them come down through the base of the skull, through the foramen magnum. Foramen magnum, okay. At each set of vertebrae, there's two little nerves that are coming out where they connect, and they go to different parts of the body. If you look at the little dermatome map, figure 19.4, it tells you where the nerve comes out that innervates that part of the body. So if I have a problem with my hand right here, it's the nerves coming out at C7. If I have a problem with the top of my foot, it's coming out at L5. Make sense? Nerves, the pulse, the little axon is the little, neuron. The neuron is what's going to pick up the signals and carry them. They're covered with a sheath of myelin. They do not directly connect to another neuron. They have little synapses. So there's little sections in between that the message jumps between. Make sense? So I'm standing next to Nicole, but she's sending me a text message and it's popping through it. All right, so you have different neurotransmitters that carry that message back and forth. Some of them are dopamine, acetylcholine, epinephrine, serotonin. Those are some of your transmitters. Under a little paragraph, it says neurotransmitters. The brain is the most sensitive to changes in oxygen, glucose, and temperature levels. The heart also is very touchy to oxygen and glucose, but the brain especially. Okay, so you have different parts of your brain. You have your occipital, parietal, temporal, frontal, limbic. You have your, then it goes on down. That's not what I want to talk about. What I'm looking for is, I was reading this way late last night after a very long day. If problems are primarily caused by the heart and the lungs, the brain is still going to be affected. When cardiac arrest happens and it doesn't get the oxygen it needs, it's going to cause damage to the brain too. Which is why after a certain point, you start wondering, are the damages going to be worth bringing them back? When you've been without oxygen for so long, there are brain cells that are dying. There's other brain disorders such as infections and tumors that can cause problems too. I had a dear soul that was complaining his foot had a weird tick in his foot, and we responded to check into it, and I went out to get the cot. He felt like he couldn't walk, that he would probably fall over. Went out to get the cot. We assisted, carried this person through the house because getting that cot in there was going to take forever, and we did not have time. I came back and his hand is now doing this. And my head said, ooh, neurological, something's progressing quickly because we went from a foot tick to doing this in the hand too. And we're moving now. So we grabbed him and we held him out to the cot. Be more specific when you explain to people how you want them to help you. Because I'm under his shoulder with his arm around my neck walking along, and I look behind and the other person has his elbow. No, you are supporting him. Get underneath and support him. What are you doing? Anyway, we got him on the cot and went over, and I wasn't sure what was going on, but it turned out to be a brain tumor that was causing it. And it had progressed really quickly when it started. I just knew it was neurologic and it was progressing, and I wanted out of there. Strokes is an interruption of the blood flow in the brain. It can happen from one of two things. It's either a block that's not letting the blood flow on by. Oh, I'm still paused. I don't want to record it anyway. Brennan has it, I hope. It's either blocking it because there's something blocking the artery and it can't flow by, or it is a rupture. We talked about the low aneurysm. something broke and it's bleeding now. It can be caused by trauma, it can be medical. I had some that had strokes at 25. They actually talk about that in here. I found that interesting. The strokes are happening in younger people.
Yeah.
Remember, time is brain. We need to move fast. That clot needs moved because part of the brain is dying. If you look at figure 917, you can see where the clot is. The rest of those vessels are not getting it. So depending on where that clot is and what blood vessels are not getting the oxygen, it's going to give you different symptoms. That's why no two strokes are the same. It depends on what the block is, how big it is, and what it's managing. Clotbusters.
Yeah. We go to the emergency room in Florida. He sat in the hallway, like they had him like not for 12 hours, and she's like, "Yeah, no, it's cruise ship doctors on what they're talking about." Took him in and 12 hours. They waited in the hallway. They're like, "You need to." And he totally.
Well, if the Clotbusters worked.
Yeah.
If you got it in fast enough, there's not going to be any damage to see.
Oh, yeah. And this presentation.
Oh dear. You hear so many horror stories from ERs. They're scary. Well, anywhere medical. The dead cells are called infarcted cells. The ones that are just sick and in the process of dying are called ischemic. So there's ischemia. This when they're dying, working on dying because they're not getting oxygen. Infarct is when they're dead. So after a MI, you can have an infarcted section of your heart that is no longer going to function normally ever again because it's dead and it's not coming back. Same with the brain. You find infarcted sections and they're not coming back either. Okay, the hemorrhagic strokes account for 13% of the strokes and the rest are ischemic. If ischemia is what's causing the problem in the heart and we give them aspirin, why can't we give aspirin to a stroke patient? Because we can't tell up here, is it bleeding or is it not bleeding? Right. Heart attacks aren't because of that little blood vessel burst and it's now bleeding. It's because it's plugged. So because of that 13%, you can't give aspirin. Yeah. If they're having a heart attack, oh, did we talk about aspirin? You should know aspirin from before. Ask them if they've had injury. Have they had a traumatic episode lately? Have they had bleeding recently? Are they allergic to it? Don't give it if they are. We had a person that I was pretty sure was a heart attack coming off the mountain. This guy is funny to hear him tell the story now. He says, "Yeah, you and Guard were having a competition to see who got the IV in. And you did the best job, just for the record." I said, "Thanks. Good to know that." Because we were both on each arm trying to get the IVs in. I was pretty sure it was cardiac, but he had had trauma during the day, so we couldn't rule that out either. Oh, it was. He was having a heart attack. It took a while before the troponin level came up to where they said, "Oh yeah, definite heart attack." Anyway, so a hemorrhagic stroke is when, especially older people, you see them more in older people. They, as you age, your brain starts to shrink. That's my problem now. Got lots of excuses. And it gives more room in the head to ping around. And your skulls, if you've ever seen the inside of one, have a lot of little pointy things sticking down. So in car crashes and any of those type of things, you can get brain bleeds from the brain slamming into these little pointy things. Or it can happen because this blood vessel here had an aneurysm and it got tired and burst. Two. You can't give them aspirin. Oxygen if needed. Use oxygen judiciously though. Just get him to Worland. Get him to Worland. Stroke is high flow diesel. Recognize it and get them moving. Get the IV started. Don't give them a whole lot of fluid because a bunch of fluid can increase the intracranial pressure. Oxygen, a lot of oxygen can also increase the intracranial pressure and cause problems. So, hemorrhagic stroke is usually a very rapid onset. I suddenly have the worst headache I've ever had in my life. There was nothing to start it, just all of a sudden, boom, I have a horrible headache, and it's getting worse. They're often fatal. Well, yeah, if you think your headaches are bad, wonder what it feels like with one of those. They'll call it the worst of my life. They often lose level of consciousness rapidly. The one I went on, the lady had, oh man, I have a horrible headache. I can't do this. I'm going to the car. And she left the lake and went up. They were fishing, went up to the car and collapsed in the parking lot. She didn't even get to the car. And they were doing CPR on her years ago, long years ago. So by the time I get to the scene of what I thought was a stroke, unconscious person, I'm told CPR is in progress. Totally changed what I was expecting. Part of, as it's bleeding out, if you look at figure 19.9, you see how as things are bleeding, that's increasing the pressure inside the skull. The skull only has so much space. So now you have this blood coming out where it doesn't belong, pushing the brain sideways. You have the brain reacting and swelling or trying to swell because it doesn't happy with what's happening either. And as the pressure increases, you're not able to get blood flow up into the brain. As it keeps increasing, where does it have to go? The only place it has to go. There's something called a foramen magnum in the base of your skull that your neurological, down there. It's going to start swelling. It's going to shove the medulla oblongata down in there. What does the medulla oblongata do? It controls your breathing. So your breathing is going to go really through all these weird things. You will see fast ones. You will see fast, slow. You will see periods of no breathing. Guard talks about watching somebody one time that was dying from increased intracranial pressure. They couldn't figure out why, and they couldn't stop it. And he said, you did. You watched the progression through all the getting worse, and then this happens. As it gets worse, this happens. As it gets worse, this happens. This is the person that made me promise I would get the ambulance running and keep it running, which is why I'm here. So yeah, someday I'm still going to smack him when I see him again. That was a terrible thing to make me promise. So you see those, and there's not much you can, there's really nothing we can do to stop it besides move faster. Right, take 293, not 77. Unfortunately, I told Aaron that 293 does not have a governor. That was a mistake. Don't go faster, you're fine. Okay, so that is usually your bleeding ones, hemorrhagic strokes. Then you have the other kind, hemorrhagic and blockages. What are the blockages called? Infarctions. That it? Hemorrhagic stroke and you get something called transischemic attacks, which is when there's a little piece of something floating that blocks the artery long enough to cause pain and some weird symptoms, and then it kind of dissolves and moves on, and it doesn't happen again for a while. So they call them mini strokes or transischemic attacks. something is causing that, and eventually it's going to get bad enough, you will have a stroke and it's going to kill you. So you do need to go in and get checked. We had a lady here that says, oh, it's resolved. This happens all the time. I'm not going with you now. And I'm going, well, okay, you have that right, but that's not what I would do. There is no residual brain damage when this happens. The signs, the symptoms are resolved as soon as that little clot decides it can move on, whatever's blocking it. So it would be kind of like the angina that you get after a heart attack. It's a temporary block thing, and then when you stop working and causing that problem, or you dissolve whatever it is with the nitro, make it open up enough, it goes away and you're fine. But as actual stroke, what do you see for symptoms? Facial drooping. Have them smile. It's interesting watching people on TV sometimes. You see them talk with one side of their mouth and not this side anymore. And you say, they had a stroke at some point. Yep. Sometimes one whole side doesn't work anymore.
Visual disturbances.
Yes, it can be as minor as visual disturbances. Something is weird with my eyes and I'm not seeing straight. It can be headaches, it can be confusion, it can be dizziness, it can be weakness, it can be combativeness, restlessness. The tongue, when you tell them stick your tongue out, that might go to one side or the other. If you come across somebody who is not responding to you and they think they had a stroke and their eyes are locked, looking up and pointing one direction, they are looking at what's bleeding. Their eyes are going that direction. And they can't move them. They're just locked there. It can be just a loss of balance. This man I was telling you about that had the increased intracranial pressure had been to the cafe on Main Street and was walking to his house a block away and started staggering and was having a heck of a time walking because the pressure in his brain was increasing. It can be decreased movement or sensation on one side of the body. Sometimes you can say, hey, whose hand is that? And they'll say, not mine, I don't know whose it is. Yeah. It's called dissociation. They really don't know, it's not mine. I don't know where it came from. It's what? Yeah, and he was having problems. If it's on the left side of the brain, you get something called aphasia. Aphasia. You can detect it by asking the patient a simple question such as, what day is today? And if they answer with something totally unrelated, like green, there is no connection between what you asked them and what came out of their mouth. That's not a good sign. It happens with the left hemisphere problems because your mental processing is over here. On the other side, you're going to have problems with your muscles. You might get the slurred, difficult speech that you can't really understand what they say. They may only be able to grunt. We actually had a person here at the school that you would ask them something and it took forever for them to process it, and even longer. You could see her wanting to answer, but she couldn't put the answer together. That's all that was wrong with her. And I get a phone call saying, please come and take this lady to the hospital. She's having a stroke and she won't believe us. So I came. She was able to speak, but it was really hard for her. So I came and said, okay. As soon as they see me come in, she kind of went, all right, I'll go. And she was having a stroke. They got the clot busters in and she was pretty much okay. Often, because they either dissociate from it or they don't feel pain, They may delay seeking help. Often with strokes, it's not them that recognize they're having a stroke, it's the people around them, which is why we try to warn, tell people. Hmm?
Real thing to that. One time I was watching and they got in my head. And they didn't see me weird presentation. And then he like signed his paper and they have a doctor like look at it, like he's having a stroke and they have already like discharged him with after and he was on back and have like full facial droop like
Because it was
didn't have
starting
that.
too early.
Yeah.
They were catching it early. They do. The bleeding in the brain may initially present with hypertension because the bleed's coming out, and then it's going to increase as the pressure in the brain increases and it's trying to get blood up there. Things that can mimic stroke. There's a lot of stroke mimics out there, just like there's a lot of heart MI mimics. Hypoglycemia can be one that can be very similar in reactions. A postictal state after a seizure, when they are totally unresponsive or very slow. I mean, they might have slow respirations. They can have, the subdural hematomas. They're often after a injury, but not always. So stroke, we're going to get 2 large bore IVs, make sure they're good free flowing, because if they're putting clot busters in, they need that IV. If it's already there, it gets them there faster. Be sure with the MIs and the strokes, call ahead, let them know what's coming. They can get them through the ER. If somebody's having an MI and you send your EKG into them, they can actually get them in and out of that ER in less than an hour and on to where definitive care is going to take care of it. They will have it on their way. If they know that's what's coming and we tell them that's what's coming, they can get that much faster and be there. Okay, seizures. Oh, any questions on stroke? Cool. Clot busters can be used in, you have about 3 to, they're saying up to 4.5 hours in some people. They can still use them. Otherwise, they have to go in and surgically get it straightened out. Oh, the scales. What are the stroke scales? Are they still in front of us, or did I skip them? They're there. Somewhere they are. There we go. Tables 19, 4, 5, 6, 7, 8, 9. The one they're kind of going to is in what's 19.8? Do you have a 19.8? Okay, 19.8 is the BFAST. The fastest what they teach everybody. American Heart is the face drooping, is the arm drifting. Have them hold their arms out with their palms up. Is there an arm going away? Speech, are they slurring their words or do they not make sense? Time, when did this start? There's another one. We need to know when it started because they need to know if they can use the clot busters or not. They also have to take the time out to run them through CAT scan to make sure they're not bleeding before they can do the clot busters. So they do have to take that long. Then they add balance and eyes to the BFAST. Did the patient experience a sudden loss of balance or inability to walk? Is there a change in vision, loss of vision, double vision, or no side or top vision? They say if you sit kind of to the side, you can tell where the peripheral vision is not anymore. And they might, I'm now only seeing here and I don't realize I'm not seeing over there. Did they lose consciousness? Their gaze. Severe dysfunction is your gaze up one way. We don't need to know that stroke. But BFAST is a good one to know. This is another case where you may not want to automatically start giving them oxygen. High flow. If they need some oxygen, give them some oxygen, but remember, people don't need to be at 100%. Keep them at 95 or below. Your blood pressure in the case of heart attacks and such doesn't need to be at 120. 90 is above 90 is where you want them at. Because we're actually causing damage trying to force them to full level when they're not meant to be there at that point in time. Okay, seizures are sudden erratic firing of neurons that cause muscle spasms, increased secretion, diaphoresis, which is what? Sweating, feel cool, clammy. Cyanosis, they can turn blue. It can be limited to just a handshaking or a taste in the mouth, or it can involve every limb and complete body and total loss of consciousness. A generalized seizure is your one that you hear most about and people know, that's a seizure. They often have an aura, a sensation, a taste, a color. One gal I heard said she saw black dots. I'm trying to think what our last patient had. She had something and knew something was coming. She knew it was coming.
We're like talking to him, and I like turn, and then I like, turn around, and I'm like, anybody, and his like head is like this, and he's just like big eyes, like he's like looking at it all, but he's just like completely out of it. Like,
Yeah.
staring at me, and
Okay.
it's like,
So
security.
if they have the aura, they lose consciousness then they have the tonic phase, which is when the body goes rigid. Then you have the hypertonic phase, as if they actually go rigid enough, their back arches. That's really ugly if you see it on when you have them strapped down to a backboard. I felt terrible, but I couldn't let them go either, so it was awful. Then the clonic phase kicks in when they all start jerking and moving. You might have lip smacking, they might be biting, they might be clenching their teeth. The contractions are very chaotic, disorganized. I like the way they word this. It says, imagine ventricular fibrillation in the brain, and that's what a seizure is electrically. So fibrillation is when every cell in your heart's all firing at once. That's what's going on in your brain during a seizure. Everything is firing and doing weird things. And after their seizure, the major muscles relax. You might still have involuntary eye movement, so their eyes might roll back in their head. Postictal phase is a reset period of the brain. It can be several minutes to an hour before they gradually return to their level of consciousness. I've seen them totally asleep the whole way to Wordland and finally wake up about half an hour after we get there. And I've seen them slowly, at first, I don't know what's going on, what are we happening, what's what? And by the time you get to Wordland, they're, oh, I know where we're at. Okay, I did this. Okay, we're doing it again. Often they can't speak. They might be confused. They might be becoming very emotional. Our last one got quite emotional. They may not be able to follow commands. They may be incontinent of urine and or feces. They may present with headaches after the seizure. Complain all the time of headache right here, our last one, right here and behind the eyes is what hurt after the seizure was over. Oh, they just, every muscle, every seizures can actually, that muscle jerking can be hard enough, they could break things. All at once, ready to go.
After all the whole phases.
They're tired. During this, the respirations can become erratic, loud, or obviously abnormal. They may stop breathing altogether and become cyanotic. They usually start again when it finally stops. Periods of apnea are usually short-lived, no more than 30 seconds. If it's lasting more than 30 seconds, you might start breathing for them. Be sure and open their airway. That might be all it needs. There are pseudo seizures. that are called psychogenic non-epileptic seizures. The root cause, it says psychiatric in origin. That doesn't mean that they are mental cases. It means for some reason it's not working. Sometimes people can have a seizure that's triggered by an emotional event, stress, lights. You hear movies anymore say flashing lights warning those who are photosensitive, because there are people who know when they see the flashing lights, they can actually trigger seizures for them. They also have what's known as an absentia seizure, where these people are just absent.
Yep.
We had a girl that would be tucking and then she would go right back where she was. She just stopped moving and would stop talking. It's typical in a child. They last normally for no more than several seconds. They have no postictal period. They have no confusion. They just, in fact, if you don't tell them it happened, they may not even realize it. It can be brought on by flashing lights and hyperventilation. They have a focal seizure where it starts in one area of the brain, and it can be motor or non-motor, involving the muscles. They may report numbness, weakness, and dizziness, and they might just have weird visual changes and unusual taste or smell that nobody else, I mean, it's not really there, it's them. The twitching of muscles can spread slowly, like the man that had the foot tick, and then when I came back, the hand was involved now. They may involve unpleasant smells, visual hallucinations. They may exhibit uncontrollable fear or have a repetitive behavior such as standing up and sitting down. There's one in Moreland, this young man, they realized after they had him hooked up to the brain, had took to all the electricity to tell when he was having a seizure, he would walk up and lick his mother's face. And that was actually a seizure. She was always, stop it. And it was a seizure.
When I worked in the injury hospital, she would get something like that. Yeah, like just random, like talking about aliens, and this would speak French. It was
Weird.
weird.
Yep. What is status epilepticus? Epilepticus. I'll pronounce it right. Okay, if they've been going, a seizure is lasting for more than 4 to 5 minutes, or they have consecutive seizures without returning responsiveness. I'm having a seizure, I don't really wake up, I'm having another one, I don't really wake up, I'm having another one. That is a true emergency. That is, if you don't have the meds to stop the seizure, that is call paramedics right away. Get them coming. I don't know. Look at that thing. They are making some of them that are like the Narcan, and you just put them up the nose and go squirt up the nose, and they can stop the seizures. Okay. With a little thingy that goes on the end of atomizer.
They also do a rectal route one, Becky.
They do.
That's what they gave us for our little girl.
Look at their medications. If they have something like Dilantin, phenobarbital, Tegretol, Keppra, Depakote, Gabaron, or Neurontin, Topamax, or Lamictal, are all seizure medicines, anti-seizures. People who have regular seizures, often you ask them if they have been taking this medication, and usually their levels, therapeutic levels, are down low, meaning they either haven't taken them or they're not high enough in dose anymore. And that's what caused the seizure. The mnemonic, use the mnemonic facts. F is focus. Was it a general seizure or a focal seizure? What are you looking at? Yes, diazepam, no.
Then you can.
Yeah, as an A, I can. I don't think it goes, I mean, as a intermediate, I don't think it goes to you guys. Activity, what were the type of movements? C is for color or cocaine. Are they turning blue or to the seizure caused by cocaine? Time, how long did the seizure last? And secondary information, medications, events leading up to, did they have incontinence? Did they bite their tongue? When actually having a seizure, keep them safe from further damage. Do not stick anything in their mouth so that they bite down on anything and cause an airway. Common causes of seizures, table 19.2. Can be everything from an abscess to alcohol, birth anomaly, brain infections like meningitis and encephalitis, brain trauma, hypoglycemia, fever. Febrile seizures are common in little kiddos. It's not how high the temperature is, it's how fast it goes up that causes those. They usually don't cause damage and they aren't permanent things in life. It can be caused by hypoxia, idiopathic, which means we don't know what causes it. It can be inappropriate medication, organic brain syndromes, poisoning, recreational drug use, especially cocaine, a stroke or TIA, sudden withdrawal from alcohol or medications that are addictive. Sepsis can cause it, a tumor can cause it, kidney failure can cause it. I've seen it with severe dehydration, heat stroke type stuff too, that actually went into a seizure. So, recognizing seizures, they can be so weird. The first one we were called to, this lady was just doing this after we got her on the cot. Turns out she was slipped something at 4th of July during the dance that she did not know she took. And that's what was caused hers, because she had fallen to the ground and had, I don't know if it was full blown or not when we picked her up. So on the way over, the whole way over, she would do this for a while and then she wouldn't. And then she would do this for a while and then she wouldn't. And we're going, that's really weird. And I noticed when she was doing this, she was looking straight up at the lights. So I dimmed the lights. And she didn't have any more the rest of the way over, which was curious. So be aware, it can be poisoning. It can be something they inhaled, something they ate. Be sure you're not coming in contact with whatever caused theirs. Some people become violent during the postictal phase. They don't know what's happening. They become very frightened. If you see signs of drug abuse, if you see tracks, if you see paraphernalia laying around, be aware. That doesn't mean it's the cause, but be aware that it's there and pass that on. What can cause other altered mental status besides stroke and seizures? Low blood sugars, drugs, infection, tumors. They might have a head injury they don't know is a head injury.
Oh, meningitis.
Meningitis, yep. Okay, so we'll get into hypoglycemia later. Syncope is fainting. What causes fainting?
Getting up.
The brain's not getting enough blood to it.
Yeah.
It can be caused by if I sit squatted down on the ground or sit on my feet for too long when I go to get up, my blood pressure, it's all pulled downhill, down here in your legs, and it has a real hard time getting up to the head. Right, vasovagal response can cause it. So for whatever reason, there's a sudden decrease in cerebral perfusion. It can be a cardiac problem. It can be a heart attack. It can be dehydration. It can be hypoglycemia. Vasovagal definitely does it. Headache is a very subjective thing. People have tension headaches caused by stress. Migraine headaches can last for many days. They can result with nausea, vomiting. They don't like lights in their eyes. They can be photosensitive. I had this kid at a Cub Scout day thing that was complaining about headache. No, he said his eye hurt. His eyes hurt. His eyes hurt. His eyes hurt. So I'm sitting here trying to flush out his eyes and make sure they're clean. It's not my eyes. He kept complaining about that one eye. So I kept trying to, he kept saying, it's not, it's not, it's not. Finally, he says, get a hold of my mom. Here's her phone number. She'll tell you what medicine I need. And it was a migraine headache. He was having a migraine. I mean, he didn't really explain. It's this, it's not my eye. I mean, the eye's what he was complaining about, so that's what I kept focusing on, and it wasn't his eye. Other cases, the causes of altered mental status are in table 19.3. All kinds of random stuff. Well, they talk about head trauma, head injury, especially a direct hit to the head. As you get into head injuries and neurological emergencies, you get into posturing. You get decorticate and decerebrate. Decorticate, they're coming up toward their core. Yep, figure 19 and 13 and 1914. Decorticate, they're coming toward their core. Decerebrate, they're going out. And that can actually get bad enough that the back arches up and they're like on their head and the heels, and the rest of them is all arched up. Those are not good things. Patient who's experienced a stroke should be positioned with the paralyzed side down. Do you ever hear that before? And try to elevate their head 6 inches. As intracranial pressure increases, especially with little kiddos, if you're looking at an infant, the pitch will go higher and higher till they sound like a cat. And the volume, the eyes, the pupils go from round to more oval shaped. So they talk about it being cat's eyes and cat's cries in the little baby that has intracranial pressure. You also see it coming up on their fontanelles that will be sticking out. Transport them immediately. If you have a stroke facility, which we do not, take them directly to the stroke center. If you think you have a heart attack and you have a cardiac facility with a cath lab in it, take them directly there. And give them a heads up, you're coming. Meningitis, you talked about, it increases the intracranial pressure. It's a bacterial infection, particularly in younger kiddos. And forms of sepsis can do the same thing. So that's roughly neurological. Alrighty, gastrointestinal. Remember where your organs are. You have your liver over here. You have your kidney below it. You've got your ovaries are down here in women, the lower quadrant. Your gallbladder's up about here. Your large intestine. Your small intestine goes down, comes up, down over to the large intestine, up over and back down and out where it goes out. You have on top of your, where's your adrenal gland? Anybody know?
top of the kidney.
Yep, sitting on top of the kidney. The adrenal gland is what's responsible for putting a lot of hormones out that need out. You have there's a retroperitoneal space that's actually behind the peritoneum. You have two layers that go around the peritoneum. One goes around the organs themselves, and the other one encloses the entire abdominal space. And it has fluid stuff that rubs between it, just like the pleura around your lungs. A visceral pain is most commonly associated with urological problems where they have feels irritated and tender, and it comes and goes sometimes. You also get something called referred pain because all of these organs share nerves with goes up the spinal cord. And so it might hurt up here in your left shoulder when what's going on is actually down here in the belly. Your abdominal organs don't have a lot of their own. They don't have really good pain sensing. So they can tell you, well, it hurts here somewhere. Eventually it'll locate to one spot sometimes and sometimes not. Sometimes they think it's up here because, well, it hurts here. Well, no, it hurts more here because it's sharing that nerve. It's not because that's where it is. So you have a lot of weird things. There can be a Mallory-Weiss tear, which is the junction between the esophagus and the stomach, causes severe bleeding. It's found in alcoholics, people with eating disorders who are vomiting a lot. And severe vomiting can actually cause that little tear in between the esophagus and the stomach. And that will be a sudden onset pain.
Everything's
So much. They say it can happen to pregnant people too that vomit silently a lot. Oh man. We've talked about hemorrhoids. Pancreatitis is when the pancreas gets inflamed. Of course, trauma to any of these organs causes problems too, but we're not there right now. Your appendix is a little recessed thing that sits over here somewhere. It frequently, when it gets infected, it can cause lots of problems, especially when it ruptures. It can cause severe peritonitis or a shock. We had a guy here in Tenslake, dear man. He thought he had food poisoning because he was vomiting and he had abdominal pain. But then it went away, so he thought he was fine. Well, what had happened is that it ruptured. But then all that poison starts spreading through your abdomen. How he didn't pick up on it faster, I don't know. But about 4 days later, when we finally got the call, they called to talk to my husband, who said, here, talk to Becky. And I got talking to the dear wife, and she said, oh, well, he's finally, I said, is he hot? Is he running a fever? Oh, I don't know. Well, can you go feel? Well, I don't really want to wake him up because he's finally sleeping. I said, no. You get in there and see what he feels like right now. Now. And she said, well, yeah, he is hot and he is. And we don't really want to. I said, okay, you either wake him up and get him to the hospital now, or I will call the ambulance and they will come haul him away. This is not optional. And yes, it had ruptured days before, and he had such severe infection, and it took many, many surgeries getting him back together again. Because it ruptured on Saturday, and this is now Thursday or Friday. So it often kind of hurts. It may center, the pain might center here in the umbilical area and then kind of diffuse, and then they'll eventually come over here to the side. The right upper. You can check for it with something called rebound tenderness. And if you come in and push on that area, put pressure on it, they don't seem to care, but let go really fast and they will say, ah! because that's called rebound tenderness and it hurts when you let go of the pressure. They are treat with diesel fuel and get them out of here. Get them fixed. Gastroenteritis is kind of a whole selection of things, anything going wrong with the digestive system. Infection of it. Primary symptom is usually diarrhea, and both infectious and non-infectious. The diarrhea may contain blood or pus. It might have a foul odor, might have bad abdominal cramps, and they might have nausea, vomiting, fever. What is anorexia? Okay, anorexia here is a symptom. I don't want to eat. I don't feel like eating. There's something called C. diff, which is an infection that gets into the GI tract, often found in nursing homes and older people. It is not killed with alcohol-based hand stuff. So using hand sanitizer is not going to kill it. You have to use chlorine stuff. Keep your hands, use gloves, wash, gown up. It just takes out all the good bacteria while it's doing it, and it just destroys the gut. Diverticulitis has gotten worse along the colon because we're not, it says with the increase of, we eat less fiber and more processed food. So, put bluntly, the poop now going through your system can be hard rocks. And as it puts pressure, it makes little sacs along your colon off to the side. That's the diverticuli. You may have them and they may not do anything, but if they become infected, it hurts really bad. And you need it cleaned up. You would? Yeah, because things get stuck in there. Ulcers are bad things. When that acid, something happens with your body and the acid balance gets thrown out of whack and it starts eating through things like intestines and stomachs, and you get weak, dilated rectums with these people. They're highly susceptible to infection and bleeding. You can get irritable bowel syndrome when they get pain at least 3 days a month. And it's caused by either hypersensitivity of the receptors, hyperresponsiveness of the smooth muscle, or once again, they say psychiatric disorder connection with the IBS. They don't know if the psychiatric disorder causes the bowel syndrome or if the bowel syndrome causes the psychiatric disorder. So they're connected. Crohn's disease can happen anywhere along the GI tract, from here to where it goes out the rectum and the from the mouth to the anus. It is usually patients between 15 and 35 years old, and it can occur again when they get 60 to 70 years old. It generally affects more whites. I found that interesting, and the Jewish descent have a notably increased incidence of the disease. It also has an autoimmune component that kicks in with this disease, and you get things like arthritis. The rheumatoid arthritis goes along with it too. Abdominal pain can present with pain often in the lower right area, can be rectal bleeding, weight loss, diarrhea, arthritis, skin problems. The one I know had super severe pain and actually left the dance they were at and went to the hospital and had a section of the small intestine removed. And interesting, they found Humira. Somebody went on the test for Humira, which is arthritis, is what it was advertised for. It's now advertised for Crohn's. They weren't going to let him go on the study because, well, you have Crohn's, that's going to throw things out of whack. But they finally did let her in the study, and when they gave her it actually stopped both, well, helped both problems. They're both autoimmune, so it helps with autoimmune stuff. Kidney stones, or when the kidney decides they have an excess of like uric acid or an insoluble salt, it makes little stones. As it goes through the urethra, it causes a severe amount of pain because the stone, there's a picture of one in figure 24. There are little rough edges every which way, and it's going through a little small diameter tube that are not meant for stones to be going through. They are agitated, restless, or they might remain motionless and just guard their stomach. If it's become lodged, you get signs of an infection, UTI infection, and or you get blood in the urine because it's causing a tear there with all these little rough edges. If you ask them on a scale of 1 to 10, they are not going to give you a 10, they're going to give you an 11, 12. Supposedly, I've heard that it's worse, the pain of those is worse than childbirth. People who've had both will tell you that. I wonder if that's because they had pain meds when they had children, but I don't know. Unfortunately, when I had children, I went in and they said, sorry, you're dilated too much, we can't give you pain meds. Thanks a lot. They gave it to me when they did the C-section, but otherwise I did not get any. If the kidney disease causes the kidneys to malfunction and increases toxins in the blood, the urine output can drop to less than 500 milliliters in a day. It's called oliguria. And if it quits altogether, it's called anuria. Remember, A and AN means no, and urea is pee, liquid. So chronic kidney disease can cause permanent problems. It can be caused by a systemic disease or things like diabetes or by high blood pressure and congenital disorders also. And interestingly enough, some infections are caused by a secondary effect of strep throat. You can get kidney problems from strep throat. As the kidney disease progresses, they later can get seizures and coma if possible. They are lethargic, they have nausea, headaches, cramps, signs of anemia, pale, cool, moist. They'll be jaundiced. What is jaundice? They turn yellow. Yellow skin in Hispanics. They have such a golden glow to begin with. It's hard to see, but you do see it in their eyes. The whites of the eyes turn yellow. Blacks can be hard to see it in. But again, you see it in their eyes or in their pink tissues. They do get anemia in their extremities and their face because of the fluid imbalances that it causes. They can become hypertensive and have a very fast heart rate. They can get pericarditis and pulmonary edema as well. They can get, is it these guys or those guys? There's stuff they call frost, where the urea is actually being pushed out. They say especially in the face, and you get this little crystallized, looks like salt on their skin, and they say it smells like urine. I have never seen it, but I've heard about it. End-stage renal disease. They either go to dialysis or they get transplants. Same type symptoms: anemia, lethargy, vomiting, confusion, shortness of breath. There it is, uremic frost, they call it. Can be present there and in the kidney disease, I think was the first one. Okay. Other problems in this area would be anything to do with the female reproductive organs are there. They talk about pelvic inflammatory disease that happens to people during the menstrual cycle. They also have, I'm surprised they don't talk about it, endometriosis. It's when your little cells that are supposed to be inside the ovary, the uterus, get outside the uterus. So every time it's that time of the month and they start filling with the blood normally inside, fill with blood out here. And then when it bleeds off, they have no place to bleed off to. The abdomen does not like blood. It doesn't belong there. It hurts. Causes severe distress. Any women of childbearing age complaining of sudden severe pain in their abdomen, what are you going to think of? Ectopic pregnancy, when that little embryo implants anywhere other than the uterus, especially if it's in the fallopian tube, because it does not expand. And as it starts growing, it's going to burst it. This is another true emergency. Diesel fuel. Get your IVs going. Yeah, because they're losing blood in there. You can lose a lot of blood in there. Yeah. Preferably put her in the back. With the men. The men get epididymitis, and I guess it's bronchitis. I've never heard of that one. Where they get infections, particularly down in the scrotal area. They can have urine with a foul odor. And I would imagine they usually transport themselves, because I can't imagine them calling us, but they could. What is a priapism? A persistent erection, painful, tender, results from diseases like leukemia and tumors, as well as blunt trauma and spinal cord injury, and actually some cocaine and certain medications, drugs for erectile dysfunction, can cause it too. So when they say, if you have a persistent erection, get medical care. That's what they're talking about. Be sure to maintain their privacy and do not make assumptions on how they got that way. That's what it says. No assumptions. As they get older, they get benign prostate hypertrophy. Aren't medical terms fun? Where the prostate starts getting bigger and it causes them to not be able to, their urine flow, it's really hard to get it started. Once you get it started, it's weak and not really there, so they have to go really often. They can't fully empty their bladder because this thing's putting pressure on it and stopping it from going downhill, down where it should go. It causes increased urination, particularly at night, and it can cause urinary retention because it can't get out. So they need to be seen. That doesn't, it could be early prostate cancer. It could just be it's getting enlarged and they need to get medication to help it shrink back down. They can get testicular masses and torsion. Sometimes there's a twisting of the testicle, and that causes problems too. Hernias is when there's a weakness somewhere and it lets an organ protrude through where it doesn't belong. There's a picture on 12/5. She immediately pointed to her umbilical. My dad has one right here. My mother-in-law has one somewhere. I think it's right there. But anywhere there's a weak place and these organs can protrude, they don't always protrude through. They can actually go through and then come back and then go through. So sometimes the bump's there and sometimes not. Oh, so if it's in the diaphragm, it can let the organs up into the chest area where it doesn't belong. Yeah, get her out of here. You don't want that. And they can be down here, and they can be in their femoral, where your femoral artery is. They can let things go down in towards your leg where it's not supposed to. They usually have pain at the site, tenderness if you palpate it. They might have a discoloration over where the area is. I know a lot of people that are ignoring these things, but if when that organ is sticking out right here and they don't do something about it and they get hit at the wrong time, that's going to rupture your organs, and that's not a good thing. They should get them fixed. Hernias can also be called, yeah, strangulation, as if enough of it comes out and it gets choked down. That will kill, let that tissue start dying. And once again, we're talking organs like your, what do I want to say? Intestines. Your intestines are sticking where they don't belong. They get choked off, it's not good. I know we had a cow that was calving one time and intestines are hanging out. Not where intestines belong. And I thought, oh gosh, she's torn her uterus, and we have all kinds of problems. And so we were trying to load her and get her to a vet because we didn't have a vet that could come to us. And while she's trying to load, she spun around and hit that, and it went, and liquid went everywhere. And I thought, we've killed her. Interestingly enough, the heifer was fine. It was the calf who had organs that had not formed inside where they belong. Calf was dead. Cow was fine. Weird thing, but yeah, organs don't belong sticking out. You're probably not going to see too many people calling us for hernias either. But for abdominal pain or tenderness, try to ask them about it, where it is, what it feels like.
Yeah.
If it's all across, if it's right here. Keep a close eye on their breathing. Be aware of referred pain. My shoulder is killing me. I don't know why, but it hurts here kind of too. You're looking at organs that are causing the referred pain. Anorexia, nausea, vomiting. If they start vomiting bright red or coffee ground blood, is there bright red or dark tarry stools? You want to know where the bleeding, it'll tell you where the bleeding is coming from. If you're vomiting bright red, it's coming from up above or inside. The tarry is partially digested, so it's been down in the stomach. The bright red is, yeah. They might have a tense, sometimes distended abdomen. Ask them about urination. Ask them about when they last pooped. That's not the use. Have you had a bowel movement lately? That's the term they use. When was your last bowel movement? What does your urine looks like when you pee? What color was it? Look for tachycardia, hypotension, and fevers. They have orthostatic vital changes, which is what? What's an orthostatic vitals? It's what? That's when lay them down and take their blood pressure. Sit them up, take their blood pressure. Stand them up, take their blood pressure. Ask about nausea, vomiting, changes in bowel habits, urination, weight loss. Have you lost weight lately? Have you had a lot of belching or flatulence? Actually, there's technical terms for that that's on their own sheet. Huh? For flatulence and belching. I can't remember what they are. But I got looking through the list of things and what the heck is that? And looked them up, and that's what they were. Pain, what does it feel like? How long have you had it? Is it constant? Is it intermittent? Do you also have chest pain? Sometimes the bowels having problems is causing pushing up and causing problems up above too. Ask about any other weird symptoms they have. Look at things before you touch them. If you find masses, be very, very cautious. Don't just go jamming your fingers in trying to feel it. Reassess them. We don't have to diagnose the problem. Give them oxygen if they need it. Don't give them anything by mouth. Anticipate hypovolemic shock. How are you going to anticipate hypovolemia? As an A, you're going to 2 large bore IVs and start giving them fluid boluses. 20 milliliters per kilogram bolus. And then turn it down to a keep open rate. Keep them as comfortable as possible. Transport them in a position of comfort. If the patient shows any signs of instability, call paramedics. when you get into the people who are doing dialysis, they do something called, they're going to have some kind of a shunt, something that's going to let them do the dialysis, connect it directly from the artery to the vein.
A fistula.
The fistula is one of them. That's the internal one, the surgical one. There can be where they take the vein and the artery, connect it directly together. I have actually heard, well, somebody told me, oh, Dad has a fistula. And I said, what? Can I see that? Please, please. And his was about the size of my thumb, about right here. Probably went that way. No, it went that way. And you can feel it. They call it a thrill. Man, that is just turbulent in there. Things are just rushing around. And interestingly enough, this man has an advantage over the infant grandchildren. Put a baby there and that baby goes right to sleep. It sounds like when it's in the womb and it can hear the heart beats. That's kind of what it sounds like. So it knocks them right out. But that is not, if you ever see one, do not start an IV in it. Don't poke it, don't mess with it, leave it be. You do not want it bleeding. Do what?
You can go on.
Yeah, I would go find a different arm.
Hopefully they have.
Yeah, I'd go find something else. Go to the feet, go to the bones, pick something else. Complications that come with dialysis is hypotension, muscle cramps, nausea, vomiting, hemorrhage, especially from the access site, infection at the access site. They also have external things that they plug in, the two things, not just fistula. They can get air emboli, they can get electrolyte imbalances, and they can get myocardial ischemia. They also get a disequilibrium syndrome because the cerebral spinal fluid gets really high with the solutes and it shifts the blood into the interstitial spaces and increases in interstitial space. Okay, we got 1 hour left. See how far we get. Endocrine. Pretty much where you have a pituitary gland that controls your endocrines. You have your thyroid. You have your adrenal gland that sits on top of the kidney. You have your pancreas. Your stomach kicks in a little bit. The duodenum kicks in a little bit. Or anything to do with hormones. So your ovaries and your testicles also contain hormones. They do. The thyroid gland is right here. You can feel it kind of, the weird little thing there, butterfly shaped. Your pancreas is in the back here. The reason pancreas is important, it kicks out other things, but it also has something called the islets of Langerhans, which is responsible for making insulin. It also makes glucagon. To kind of control the blood sugars, it uses one of the two. So the reason I ask about the adrenal gland, there is something, seems like it was called Huntington's disease, where the adrenal gland quits working. And they end up really weak, they gain weight, they are tired all the time, they get a really dark pigmentation to their skin. Very, very dark compared to the sibling. It's almost night and day between these two. It's supposedly really rare, but I know of at least 5 or 6 here in the Bighorn Basin. One is in Moreland, if she's still there. Most people don't know about it. This girl over in Moreland was actually down to where she was in a wheelchair and she was having no time going to school at all. What? I think it's Huntington's. Huntington's. It's not in your book. You're not gonna find it.
Addison's. It's Addison's.
Addison's disease. Thank you. Addison's disease. You're right. And when they took her up to Billings, and the doc at the Billings took one look at her hands and her tongue and said, she has Addison's. I can fix it right now. And she'd been all over the place trying to be fixed. You get this weird puzzle pattern to their hands and their mouth. So when I saw this girl again, I said, "Can you stick your tongue out? Let me see your hands." "Oh, cool." Just because, I heard about it and just want to know what it looked like. Not something you'll find, but it's because that's not working. And so now they have to take a concoction of all kinds of hormones regularly to keep their body functioning. Okay, so the first one we will talk about here, hypothyroidism and hyper. If your thyroid is not kicking out enough thyroid stuff, you're going to feel really weak and tired all the time. If it's hyperactive, they actually go in and kill it and put you on thyroid medicine. If it's low, they put you on thyroid medicine. So if you have a sudden rapid weight loss, if your hair is suddenly falling out a whole lot faster than normal, go get your thyroid checked. Or if you're suddenly feeling super tired. It's amazing how many people are on thyroid medication. Diabetes. There are several kinds of diabetes, but your symptoms are polyphagia. You have an increased appetite because your body's saying, "I need more glucose, I need more glucose," so you keep eating more, so you gain weight, possibly. Polydyspnea, you're super, super thirsty and you are drinking water like crazy, like gallons a day. And very thirsty. Which would you get along with drinking gallons of water? You got polyuria, frequent urination. If you're drinking all this water, it's got to go somewhere, so you're running to the bathroom all the time, even in the middle of the night. Diabetes mellitus has to do with them not being able to function, to metabolize that glucose the way it should. Mellitus comes from a Greek word for honeybee, which means sweet. So that's referring to the presence of glucose in the urine. Many, many years ago, this is not going to be in your book. We're back in like biblical times. They knew somebody had this because ants would go to where they peed. Because that's where the sugar was. They would see ants going there. And they would say, "You're going to be dying soon," because there's nothing they could do about it. They didn't know what was causing it. They just knew they were going to be dying soon. So, diabetes can be a principal cause of kidney failure. It can cause a lot of problems in the heart. It can cause blindness. It can cause neuropathy. Most of these are caused from the high blood sugars. The continuous high blood sugars are what cause the complications. Make sense? And the low blood sugars are what's going to kill you fast instead of long term. So, different types. There is a gestational diabetes, when women can develop diabetes when they're pregnant. And it goes away after pregnancy, usually, not always. There is type 1 and type 2. Well, first, they have really bad circulation. If you look at figure 21.5, this is what the feet look like. My father-in-law actually had a huge ulcer like this on the bottom of his foot that wouldn't heal. If he would stay off it and they worked on it really hard, it would kind of heal up and then he'd walk on it again and it would go right back through it again. They have a really hard time healing because their circulation is garbage and it's not getting down there to heal. When you go in for surgery, I know someone recently who wanted knee replacement and couldn't because their blood sugar was too high. I know someone that wanted their hernia repaired and couldn't because their blood sugar was too high. They have to wait till the sugars get down because they're not going to heal normally. That's partially why diabetics are weird with every other disease that you ever come across. You're going to say, "Oh, yep, diabetic, the old people, the young people are all weird." You'll come across people with undiagnosed diabetes. It can be young or old. Somebody recently said, "Oh, I diagnosed somebody with diabetes today at school." That was one of our school kids that was low. So type 1 has historically been referred to as insulin dependent, or it's called juvenile diabetes, because usually it affects kiddos. Type 1 is a hereditary predisposition. Genetically, you're either going to get it or you're not. The reason it's actually triggered, the right virus comes along and it triggers that diabetes. It really doesn't matter what you're eating, what you're not eating. Once it gets triggered, what your body does is it decides it's going to attack those islets of Langerhans and it starts killing them. Can putting that person on a diet make it better? No. You can't produce insulin if you have no islets of Langerhans to produce the insulin with. So as it starts killing them, the sugars go up higher and higher because your body needs insulin to grab the sugar and put it into the cell. They both have to be present. Adults over 30 is called latent autoimmune diabetes. I am told someday, it's not if, it's when I become diabetic, I will be type 1. Apparently, I'm the one that had the fun genetics and passed it on to my son. No idea where it came from because we don't know anybody on either side of the family that had it in the past. But I do have 2 of my children now have it. So they have to take insulin to keep their glucose levels. It does matter what they eat. They do watch and follow strict diets because some things are much better, some things are bad. They have to be very careful when they're out working. When their son number 1 was 10 years old when he was diagnosed, he still played basketball, he played football, he was in the All State Marching Band and marched through a 5-mile parade route in California. And he was just fine because he was aware of it, kept track of it, and took care of it. Yep. Now they have cute little things that go under your skin to keep track of your blood sugar. It talks to your phone. So, yep, they can talk to the parents and say, hey, your kid's low. They call the school and say, hey, my kid's low. Go give them a snack right now. Then they have fancy pumps. And now they're starting to get to where this is talking to this. And they no longer have to do anything besides make sure there's insulin in that pump. All this has happened in the 28 years we've been dealing with it. Because he had to start taking 2 or 3 shots, well, 2 shots in the morning and another one every time he ate. Because one was the long-acting stuff and the other one was when you ate.
I have a question for you, Becky.
What?
I have a question for you. That patch that you see on people's arms, does it have a needle inside?
It just goes into the subcutaneous layer, into the fat layer.
Oh, okay. And how long can they have it there before having to change it? You know?
Some of them are a week. Initially, the things were like 2 to 3 days.
Okay.
Well, 3 or 4 days.
Okay. Thank you.
So yeah, it's not just, it's a thing that actually sticks out usually, not flat like a medication patch.
Yeah.
It's a, yeah.
Yeah.
And the pumps, figure 21.6 is an insulin pump. It's about the size of a pager and it's clipped to them and it will have a tube coming out the top and it goes just under the skin. So they've got a little thing somewhere that's stuck to legs or arms or their belly area.
Okay. Thank you.
Type 2 diabetes have the same. They're tired. They have nausea, frequent urination, unexplained weight loss. This kiddo went from 75 pounds to 65 pounds in a short time period. They can get frequent infections, blurred. They get cranky, confused, shaky, unresponsive. They eventually can have a seizure. If you have a kiddo, I will tell you all this now, so hopefully nobody goes this long. They're having flu-like symptoms. They're vomiting. They're peeing. They're drinking because they're thirsty because they're vomiting and they're peeing. And they have no fever. Check a blood sugar. Yeah, check the blood sugar. Below spells. because we thought the kid just had the flu that was going around the school anyway. He was home for one day, he was back at school for a couple days, he was home for one day, he was back at school. He was running all over the ranch, and I did not notice the weight loss, I must say. He didn't lose 10 pounds in one semester time period. They do. This kid didn't have fat to begin with, so he was, you know, very big around. So that is type 1. Type 2 is usually considered adult onset. They sometimes are on insulin. So just whether you're on insulin or not is not depending which one you are.
Right.
It's whether or not you still have islet cells, basically, or not. You have the same symptoms. You can become pre-diabetic where they tell you you're going to get it and you're starting to have the symptoms. If you have an A1C level, that's a test. A1C gives you like an average of what your blood sugars have been over the last 3 months. So it's not just, oh, today I didn't eat anything and yeah, I'm 40 right now. It's over the last 3 months, you averaged 400. Get looked at and get it fixed. Being overweight is a risk factor. There is family history. So if parents or siblings have been diagnosed as being type 2, your odds are higher. Interesting, it says African American, Hispanic, or Indian, or Pacific Islander. Increases your odds. Babies who weighed more than 9 pounds when they were born have an increased risk. Being physically active fewer than 3 times a week increases your risk. You all know how to do glucose testing, right? Okay. That used to be a more advanced skill, and I thought it was ridiculous. So A1C results are what tell people, yes, you've been too high, or no, you're too low. There are people that run around with hypoglycemia on a regular basis, and they have to be really careful what they eat. If you don't eat a lot of sugar and you eat the more natural stuff and more protein to try to keep those sugars level, you do better. So just being hypoglycemic in itself does not make you diabetic. Type 2, the reason they become diabetic is for some reason their body is no longer able to use their insulin. And type 1, you're not making it. In type 2, there's a problem with it, whatever the problem may be. That's why they can give them medicine of some kind that may fix whatever the problem is, so that they also helps them lose weight, so that it will get better. Some people never have to go on medicine. Others eventually do. So glucagon is a medication that people carry. I hear some people using it a lot. Glucagon causes the liver to dump its sugar reserves into the bloodstream. And it works super great if it has anything in the reserves. It's in here somewhere. It's something that's released from the pancreas also. But if it's not working, glucagon shot is one that people can use. If you have an unconscious patient, you can't give oral glucose. Glucagon's the shot they would send home with you and say, here, give them this instead. Paramedics carry glucagon. I think we're authorized to do glucagon, but we don't carry it. So what it does is, yeah, it dumps the sugars. If they've been down long enough, they're not going to have sugar reserves in the kidneys, in the liver to begin with. So there's nothing to dump. So it's not always going to work. Don't rely just on it. The high blood sugars and ketoacidosis are bad because, as I say, the continuous highs cause a lot of problems, and they start messing with different levels in your body. They make you really acidic. They start breathing off really fast, the Kussmaul respirations, where they're trying to get all the restore the acid-base balance. DKA can happen because you're not controlling the sugars to begin with. It can also be caused by, where'd it go? Alcohol use, emotional stress, and illness, such as a stroke or a heart attack. People who are diabetic, when they become sick, like just a cold or something, an infection, their sugars go out of whack and you cannot control it with insulin. You need to go get antibiotics and get that infection under control, so then you can get the sugars back under control. People with really super high blood sugars are not fixable in the pre-emergent setting. That's why we don't worry anything about the high numbers. Well, we do worry, we take them over and let them fix it. But it's not our department to fix it. We do not give them insulin. And Dr. Acey explained that, which I've wondered all these years. He said that as you're dropping those blood sugars, it messes with the potassium. Potassium is needed to keep the heart functioning. And if you start throwing that out, you're throwing out the heart, you're doing a lot of bad things. So that's why we don't, it's not our department. We send them to the hospital and let them under a controlled environment where they can have more meds to fix everything as it messes up. Okay, so what are the signs, the differences between a high and a low blood sugar? Then, what are you looking for in a high blood sugar?
Like the skin temperature is gonna be high. Is that
Can
high?
be. Hyperglycemia can be from excessive eating. Hyperglycemia, the highs are usually slower to onset. The lows can be really sudden. The high sugars are warm and dry. The low sugars are pale and moist. So they're shocky because they are in shock. The highs can be warm because they're have infections. The lows don't usually connected to infection. The thirst can be intense in both cases. Vomiting is usually when they're high. The rapid breathing. When they're low, they can be normal to rapid. When they're high, they're really rapid. The odor of the breath is, the ketone odor is when they're high, not the low. Both can have low blood pressure. Pulse can be rapid and weak on both of them. They can be starting to get restless and get in like a coma, can be either high or low. A low does not have sugar in the urine, the high does, because all the sugar's been building up and it's getting peed out because they can't do anything else with it. The glucose level, a low is considered, oh, now they're saying below 60 is a low. Hyperglycemic, interesting, the book says over 600. Anything, they're saying 70 to 140 is considered normal, so really anything over 140 is high, and anything below 70 can be low. Oh, after you've eaten, yeah. Now remember, when you eat food and it takes about an hour to digest, your sugar is going to be higher than when you're not. We're talking like fasting sugars here. Which is probably why they allow more of a dip and go. What kind of symptoms do you see in a low blood sugar? They can, very altered mental status. They can be totally unresponsive. They can space out and just stare into space. They can become super combative. We had one here at the school that would go ripping through the school and battling off anybody who tried to help him. Didn't want anything to do with you. We found out when he was trying to operate the pop machine to fix his sugar, and it wasn't working for his brain wasn't functioning well enough to be able to get the pop. And somebody, no, not my son. Somebody came to offer help, and this person just went freaked out and ripped him through the building, and they had to tackle him and get him to sit down. And they still couldn't get a blood sugar out of him to test him. They called me right away, of course. And I could manage to get blood out, no problem, and found out he was high, and he was low. Gave him some sugar, made sure he took protein. If you give him a sugar, remember when you eat sugar, your sugars go up really high, and then they go when the insulin's gone. And you still have the insulin there, but you don't have the sugar there, so it drops down because it's all gone to the system. So if you have to give someone who's diabetic sugar, recommend they go eat protein with it. Because things like peanut butter help level it out. Your glucagon is figure 2111. It's supplied in a cute little syringe and an ampule, and you have to reconstitute it and pull it up and give the shot in the muscle. Your glucose comes in a paste, or that paste is not around much anymore, so it's either a little liquid shot thing like you can find in the you see them at checkout stands, just a little shot. That's not what you're looking for. But the sugar comes in a similar thing. Like those, but not those. They look like that, but it'll say glucose. They have little packets you can rip open and let them just. Technically, it tells you to put it on a tongue depressor and stick it in between the tongue and the cheek so that it's pointed against the cheek and it gets absorbed through the mouth faster. Most diabetics I know will grab it out of your hand and go and slurp it in and swallow it. There also comes as tablets. You can give them so many tablets and have them crunch them up. They're kind of fast as all pleasant tasting things. You what?
And he went into the kitchen, grabbed a spoonful of sugar and tried putting it in her mouth.
Was she conscious or unconscious?
Yeah.
Okay, nothing oral if they are unconscious. But yes, you can use plain table sugar. You can use honey. It comes in cute little sticks, and it's even flavored sometimes. The book, wherever it was, I read was telling you that you could do chocolate. Chocolate is not a fast sugar. It's a slow sugar because it has a lot of fat in it. So it's not necessarily what your choice, chocolate. It's slower to absorb. It's not fast. Jelly beans, Skittles, pop, the stuff with sugar, not real sugar, but sugarful, not diet. Juice is very good. Orange juice is great. Any kind of juice. So that's what you do for lows. Give them that stuff. If you cannot, that's when you go to make sure if they're not conscious, you start the IV. Make sure it is very good free flowing, because if you ever Google what a sugar injury caused by glucose injury, it eats away the tissue and makes these really big, ugly sores. Do it? Yep. Tape the IV in really good. You do not want that leaking out at all. Then they give you what they always taught us to do is you get this thing called D50. It's a tube about yay big. You screw it on and you push it in, and you're giving them 50 milligrams of glucose. It is 50% glucose in that thing. It's a little thicker. Guard always said, oh, it's really hard to push. Come push this and see what it feels like. There's things we give the cows that are a whole lot harder to push than that, but because I said, that's hard. On our rig, we've gone to what I really want to be carrying is D10. It's only 10% glucose. So it's not as necrotic as the D50 is. What we're carrying right now is D5, so it's not very much. For kiddos, you want to give them the D25. So you want to dilute the D50 or give them the 10 and you adjust your how much you give them according to what your concentration is, but you want to thin it down. If it's eating the tissues in your skin, think of what it's doing to your blood vessels that you just shoved D50 in. The diabetic people told me, never, 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 never. What? You do what? Never. They come to just as fast with D5 or D6. It flows in really beautiful and you don't have as many complications. Okay, hematologic, and we're going to quit at the end of this one. I don't remember what all we had after this, but well, we can cover that one quick too. There are some people that have blood disorders. The main one is that they talk about is sickle cell. That usually is in the African American population. Their cells are deformed. If you look at the picture in figure 21:13, you can see the normal blood cells are round and kind of dished, and they get these weird shaped things. And because of the shape of them, they cause plugging. They call it sludging, where they get big groups clustered together and it causes severe pain and it blocks the artery or the vein. And they can get acute chest syndrome where it feels like they're having a heart attack. So you need to get them to the hospital and let them figure out how to fix it. You have people with anemia. They're really tired all the time. You have clotting disorders. There's people that just bleed super easy. There are people that are on medications that make them bleed super easy. There's hemophilia, which causes people they don't clot. There's things when you talk about people with clotting disorders, Leiden factor 5 is one of them that will cause blood clots. That's hereditary. So in a hematologic emergency, you're going to keep them comfortable, get some fluids going so that they can give them the medication they need. And transport, you might need pain management. Be supportive. Psychological support is the most best. Stay calm, be supportive in whatever they're telling you. That takes care of that one. Immunologic is pretty much allergies. What are we doing for them? Okay, if you look at 22.2, what do you see in there? 22.2. It's what? No, figure.
Hives.
22.1. You see cute little red splotches everywhere. It's a reaction to the medication. That's not, it's kind of a hive. Hives aren't as red. Maybe it's just because his is more. Oh, there you go. 22.3, that's hives. For the record, those things can get, well, there is a pretty good sized one right there by his spine. They can keep growing and they can grow together and you can end up with a hive about like this across your back. Because when you go get allergy tested, they make you get off all allergy medicine. And they grow to huge. And then they say, oh, I have nowhere to do my test. Well, don't make me get off the medicine. If you're going to get allergy tested, do not get sunburned the day before either, because they can't be red. That's what they're looking for, is redness and swelling. And if you already are swollen and you're red, they can't find it. There's something that your body suddenly decided is the enemy, they're attacking it. And this is part of how they attack. Hives are not life-threatening. They're terrible, especially if you get them in between your fingers. But in my opinion, those are the worst. I had hives for 6 months, by the way, guys. That's why. In the fingers is the worst. I just wanted to rip my skin off because they were terrible. So some allergic reactions, it might be sneezing, itching, watery eyes. You can get a cough. You can get a little bit hoarse. You can get hives. You can turn red and get flushing and rashes. You can get some abdominal cramping, some anxiety, headaches. Those are just an allergic reaction. What makes it anaphylaxis then? Okay, you're starting to get stridor, tightness in your chest or here in your throat. You feel like you have a lump in your throat. You can't breathe. You can hear wheezes and crackles. You can actually hear stridor here as they're breathing in. You get really tachycardic. Your blood pressure can tank. You can get cardiac dysrhythmias. You can still have the hives and the warm skin and the swelling. Your face starts swelling, your hands and feet and tongue swell. That picture of the guy with the big old tongue. When this swells enough right here in your airway, you start talking hoarsely because it's swelling and you can't talk normal in the vocal cords. And it gets to where you can only whisper. So when answering questions, be aware you may have to listen very carefully for your answers. When you hit that point, that's where the epinephrine is needed. The only true what do I want? Indication. Contraindication is a sensitivity to it. If it makes your allergy worse. You're going to give epinephrine, an EpiPen, you're going to hold it in your hand, you're going to, come on, finger. You're going to pull the little cap off, hold the middle of it, so the point's at one end and the other's at the other, pull the cap off. You're going to hit it right in the middle of the thigh on the outside part of their leg. You're going to hold it there for like 3 seconds, and then either you or they rub the spot. Now what you're going to be doing is drying it up in a syringe. Does anybody know what the dose of epinephrine is? For an adult is 0.3. For a ped, 0.15. So you're going to draw that up. You're going to go usually in the muscle here in the arm. Put the needle straight in, pull it back, make sure that you don't have any blood coming up in it because you don't want to put it in the artery or vein. And then you inject it again, rub the spot, and watch for it to get better. If the allergic reaction is stronger than the epinephrine, which it's got a half-life, I don't know, about 20 minutes or half an hour, and it's halfway gone already, you might need a second dose. So don't just give them an EpiPen and walk away and say, woohoo, you're good. Take them with you and get them over there to get checked out, especially if they don't know what it is. Okay, toxicology is poisoning. Where are the places? How do we get poisoned? What are the pathways? How do they get in you? You can eat it. You can what? You can eat it. You can inhale it. You can absorb it. You can inject it in there. Or critters like snakes can inject it in there. I think you covered them all. They have the activated charcoal picture in here still. They don't really use, I've never seen that used, in all honesty. Use it in dogs. Pretty much Find out what it is that they ingested or whatever it is. If it's inhaled, if you show up to a scene and you see everybody sick at the same time, coughing, hacking as they come walking out of a building, do not go in the building. If you are out in the Badlands in the oil field and you see people going down, don't go charging in there, because if it's H2S gas, you're going to go down just as fast. Yep, sorry, can't help you. If it's on your skin, brush it off, wash it with free-flowing water. If it gets in your eye, you flush it out with lots of water. If it's in one eye, make sure it doesn't get pushed to the other. If it's injected, that's where we need to take them. People put the dangest things in their bodies anymore. Find out what it is, try to find out how much was taken, how much the person weighs, how long ago it was, if somebody done, what interventions have been done, have they vomited or aspirated, call poison control, find out what they have to tell you. You can call the ER, but what the ER does, unless they know the answer right away, they're going to call poison control and call you back. So save yourself a trek, call poison control, find out what you need to do about it, and get going to the hospital. Not everything can be fixed out in the field. If it's something that's going to be a long process, start the process while you're driving. They have it. If you get bit by a rattlesnake, let the hospital know you're coming and what you have. It takes about half an hour to get it ready to give. So if we call from Tin Sleep and say, Worland, we're coming in with a snake bite, it's ready when we get to Worland. So be on top of that. Be sure to include things like antidepressants, organophosphates. Be very bad. There's special things for each one. They're in here. There's things like Sledge they'll have you memorize, and yep, read through it. We don't get a whole lot of poisoning calls, but we do get some. Be sure you're treating them appropriately. Don't just, oh, look, we have charcoal, says it's for poisoning. Here, take this. Charcoal, for the record, this could be a test question. I've seen it often. The activated charcoal is crushed up really fine and it's put into this liquid. And it has a whole bunch of little surfaces on it. And what it does not absorb the poison, it adsorbs the poison. It's ADSORB. And what it does is it grabs it and it takes it out through either vomiting or through the digestive tract. And so if that's something that they need out of there really quick, it can go in and grab it and pull it out. Oh, that takes us to behavioral. Good, we'll stop there. Do we need to stop there? Yeah, we got 15 minutes. I don't know, I bet we can get through psychiatric. What do we need to know about psychiatric patients? Don't be condescending. Don't be judgmental. Don't try to talk logic to someone who is not logical. What if, how can we tell if they're going to be hazardous to us? They start getting angry. They start getting tense. They start getting, if you see, yes, they start looking at you like, I'm going to get you. Be aware. What are some things that can cause abnormal behavior, psychological behaviors? Trauma, hip head trauma, low blood sugar, drugs, low hypoxia, hypoperfusion, meningitis, seizure disorders, toxic ingestions or overdose, withdrawal from said substances, taking them and withdrawal from them. Try to stay calm. If there's any danger to you, be sure you have exit route that you can get out of there. Don't turn your back on them. Don't let them trap you in a corner. Be aware these people have personal space they don't want you in. So don't just go running up to them and, hey, how are you? Respect their personal space. They can have anything from PTSD to functional disorders. Unfortunately, there's still a lot of people in this world that say they're just crazy to begin with. There's usually a reason they're the way they are, and it can often be dealt with and fixed. Even the ones that are on the psychiatric medications, maybe they quit taking them. Maybe they took too many. So they talk about their consciousness. They can be anywhere from distracted easily and not paying any attention to you. They can be in a coma. They can be confused. They can be in delirium. They can have repetitive movements that don't seem to have a useful purpose, restless, slow speech, super fast, really pressure speech. I want you to know right now. Pay attention. Words that they invented. Maybe Terrell has that problem. Maybe Terrell has that problem. He likes to invent words. They might be echoing what they heard. They might not speak at all. Their ideas can go rapidly from here to here to here to here to here to here, which my brain does sometimes. So maybe they're right. I do have problems. They have delusions or false beliefs. Do we go along with their delusions? We had a lady who we were called because she was psychiatric problem. She's sitting here petting her dog, telling us her dog died and this funeral was today while she's petting the dog. And she went through all kinds of, this is what happened at the funeral. My dang husband, he did this. And none of it happened. The dog was sitting by her. So no, we try not to play along with them. Try to keep them calm. Try to calm them down. Does our anxiety help them at all? No, don't ramp up. If they start ramping up, go quieter. Go more still. Calm down. Do what? It is hard to deal with. Stay with the patient if you can, especially if they are threatening harm to themselves or somebody else. Don't fight with them. Try to keep a safe distance. Don't let them get a hold of you if you can help it. I mean, you do need to get vitals if you can, but if they're going to grab a hold of you and strangle you, stay far away. Be honest, reassuring, don't judge them. Oh, you're just a drunk and you've had too much to drink. Again, why are you bugging me? That's not acceptable. Pay attention to how they respond to you and how they feel. These are the people that I take into the hospital, and while I'm writing my run sheet, I hear them screaming and yelling, and the docs look at me and say, did you have to bring them here? Was I really the closest facility? Well, yes, you were. Yeah. Yeah. I remember these people that have these experiences regularly, not regularly, but often because of whatever's going on with them. They don't have necessarily good experiences in the hospital.
And so
They pre-assumed, made assumptions that we're not supposed to do. Take a good history of what's going on, find out what meds they're on, and have you been taking your meds? Have you had any injuries lately? They used to call something called excited or agitated delirium, which was a big problem that was often associated with meth and some of the other drugs, where these people are really combative. They're out to get anybody and everybody. There's one, I can't remember what it was. I don't think it was meth. No, it was something else, where the guy in Florida had tackled people and were eating their face. Yeah, the bath salts. He was eating their face. They rip their clothes off and they go streaking through the world naked and hot. They're running really high fevers. They're just pumped and everything's going crazy. I'd take the quiet, goofy ones long before those guys. Yeah. Remember your scene safety. If these people are not safe, get out, call your officers. They teach us to restrain people, that we need at least 5 people, 1 to take the head, 1 to take an arm, 1 to take an arm, 1 on each leg. And you got to all be coordinated. You walk up and they're not going to be suspicious at all that 5 of you are walking towards them. And you're to take them down all at once and you tie them down, and we don't really do that. You might be called upon to assist. I know sometimes in the ER they've had to do that with the officers and they need EMT's help. I have had to tie somebody's arms to the cot, the little side things that flip up on the side. We just tied her arms to it or to the backboard. Don't restrain them face down. Remember some people that have PTSD. PTSD is not just military. It can be abused people. It can be anybody who's had such traumatic that it causes PTSD. Remember that as you come ripping up into their situation and in their face, you might be sending them back to what their triggers are. You might be triggering the problem. So be careful and respect that. And with that, pretty much maintain calmness. I find calm has a real good effect. Sometimes it might take a lot of patience trying to get them to where they will finally talk to you. You have to wait for them to calm down enough that they know you're, okay, this person's really going to listen. Maybe I'll tell them. And get to that point that they can answer your questions and we'll talk to you. And yes, they probably need transported. And with that, I'm going to write off today and we'll do the gynecological stuff another time. And I will see you next Thursday, right?
Monday. Is that Monday? I think
This
it's
is
Monday.
a Saturday class, so the next class is Thursday.
Hold on, let me look at the
Oh,
schedule.
by the way, the dates, I was pointed out the dates in November, October were incorrect. I corrected them. There is a Monday class and then a Thursday class because I'm giving you a whole week off at hunting season time.
Okay, so
Because
next class
it's
is
hard to find
Thursday.
people.
Thursday then, Becky.
Yes,
Thursday.
next Thursday.
Okay, perfect. Thank you.
Talk
Have
to
a-
you Thursday.
Have a nice weekend. Bye-bye.
You too. Bye. I think I did in an email recently, but you can go to your email.
Hey, Becky, did you let us know how we did on the test?
No.
Okay. Well, no worries. I'll just retake it if I have to. So that's why I was asking.
You sent me the answer sheet, right?
Yeah, email.
Well, he's there somewhere. I don't see his face. He has a voice.
My camera's not working right on my computer for whatever reason. So
See how you are.
I thought you disappeared.
I did. I'm very sneaky that way.
What?
I said I'm very sneaky that way.
Yeah, we know.
She says I'm ahead, so we went ahead of going into psychiatric.
Perfect.
Cool. Thanks.
Thank you. Bye.
I'll get to my email box and get back to you.
Yeah, no worries. I'm in no hurry.
After about 4 o'clock this afternoon, I have time that's my own again.
Yeah, whenever. I'm not in any big hurry. I just hadn't seen it, so that's why I was asking.
Okay,
Cool.
thanks.
Thank you. Later.
Bye. Give me your answer sheet.
So I talked to Sarah yesterday, and she was like, "This country's gonna hate me forever if I grab her." Becky's not gonna hate you forever.
She'll give you a hard time, but she won't do it.
I said, "We'll just expect it by the next."
Or at least you'll get.
I don't know about me. You know, too. I'm not one.
But what is the problem with us?
Did you get more chickens?
No, I didn't get more chickens.
Or did you get more up?
Does he? No, he got this today. This is what we want.
See ya.
Yes, he got this today.
Did you make that?
It just said that. Yes. Oh, the birthday was last week. No. That is what I've been working on. I think that's why you have to leave it now. Yeah, because I gotta do more of my too.
Okay.
And I'm supposed to be playing piano, you know. I'm gonna stop it in your free for the church. I don't know. If you said what I want, okay.
Okay, I'll be there.
So, that is her dress, and unless they came down for it and Carol gave it to her, in which case I said, I want a picture of her face when she sees it, and I tried it on, just the plain satin with the lace around the bottom and just the plain top.
Yeah,
It didn't have all that other,
you're gonna love it. Yeah,
she will love it.
she's gonna love it.
She is definitely a princess and will adore every minute of that.
Anyway, see you guys.
I'll in on Thursday.
You know what?
I'll have to zoom in on Thursday.
All right. See how you are. How long are you gone?
Huh?
How long are you gone?
I'll be back Saturday, the 30th. So we got 3 classes.
Okay.
10 days.
You're running away for the rest of the month. You're running away for the rest of the month. Angie, Barbara, Regina, McKenna,